Everyone, how are you doing today? And I hope that you had a great weekend. And we are on our 45th of the 90-day free NCLEX review sessions. And for those who are new to the channel, we are inviting you to join with us with our review sessions. We still have about half of I think we're gonna have 45 more days to go for the free NCLEX review sessions, and we are also inviting you to enroll into our NCLEX program and kindly visit at www.stancoastnclexcoaching.com. And we have updated our library just recently, and so we are going to offer you a lot of courses there. We have about 3,000 NCLEX practice questions. We have also the 200 hours of recorded lectures plus the 20 hours of animated videos. And we still have the resources like the audiobooks and also the flipbooks and extra mock testing. And so this is something that you can access for the entire 6 months, and this is included in your subscription. Hello, can you hear me? All right, let me check what's going on here. All right, what's going on? I have my volume already up. Hello, can you hear me better? I have already my volume up. Sound check, sound check, sound check. How is that? Does that sound better? Can anyone confirm if the sound is better this time? Good morning. For those who are in Asia, good morning. And for those who are watching from the North America or Europe, okay, that's good. All right. So again, we are encouraging you to check our website for the course offering, and please don't forget to hit the like for this video, and also don't forget to share and also subscribe to this channel. And we really want to make sure that you're updated with our schedule. We're doing this every day, actually at 9 p.m. Eastern Standard Time, and so make sure that you're up to date with our sessions. Now, today we'll be talking about the different types of leukemia, and we'll be doing some practice tests as well. And so hang tight. We're going to go through with all those as soon as we're done with the theoretical component of this presentation. And so guys, again, welcome. For those who are new here, welcome to the classroom, and I hope that you're going to learn something today. So let's talk about the acute leukemia, which is basically the most common type of leukemia. This is considered as a progressive and very rapidly developing cancer that can develop in the bone marrow. And this will affect the blood and also the blood forming tissues. And so what you're going to expect here is that the person will have problems in their red blood cell count and also the white blood cells and the platelets. So it's just not about the anemia that we're going to worry about in a patient with acute leukemia, but there's also going to be issues with their clotting, and also they're predisposed to getting those opportunistic infections. So again, don't forget about the blood groups that will be affected in acute leukemia. We have the white blood cell production is impaired. Same thing with the red blood cells and the platelets. So these are the blood groups that will be affected greatly, especially when a person has the acute leukemia. Now, what is really going on with the acute leukemia? Well, this is an abnormal proliferation of the immature blood cells. Okay, so don't forget about this characteristic. This is the proliferation, abnormal proliferation of the immature blood cells. we call them as the blasts. Okay, so this will really interfere with the normal blood cell production. Again, immature, which is it's different from the chronic type of anemia, because what they're going to have is abnormal proliferation of a more mature type of cells. But here, we're going to encounter more of the immature blood cells known as the blasts. So what's going to happen if this is going to occur? Well, again, it can interfere. It can affect the production of the normal white blood cells, also the red blood cells, and the platelets. Now we're going to talk about the different types of the acute leukemia. There are two types that we need to know here. If you have forgotten about the concept, then it's time for us to get yourself refamiliarized to the following. Okay, so let me just erase this ahead of time so it doesn't obscure the view. So what are the following types? We have the acute myeloid type of leukemia, and the other one is the acute lymphoblastic leukemia, or known as the ALL. So we're going to have to compare the two according to the different characteristics. So we're going to have to compare according to the origin, how it's going to affect in an age group, or the possible contributory factors, or maybe how are they going to respond to the therapy, or the prognosis of each. Okay, so we're going to go through the comparison here. So let's take a look into the acute myeloid leukemia, which is referred to as the AML. So this is going to occur mostly in the myeloid progenitor cells in the bone marrow. Okay, so talking about the AML, this is going to originate in the myeloid progenitor cells, whereas we'll talk about the other one later on, so hang tight. Now, the incidence of this condition, it can affect more in the adults, and this is going to occur mostly around the 68 years median. Okay, again, this will occur more in the older adults with a median age around 68 years. Imagine that, affecting an older person. Now, what about the risk factors of the AML? Well, again, one is the age. Another is the exposure to the radiation or maybe the chemicals, and also some syndromes. Maybe the Down syndrome can also predispose this person. Now, let's talk about the responsiveness of the AML to the chemo or maybe adjunctive therapy. Well, this is going to be less responsive. Generally, it has lower responsiveness, and it will really have a hard time in achieving this called remission. Okay, so understand now, guys, that the older person, of course, with AML, they're gonna really respond to the chemotherapy. They're not gonna achieve that, or maybe they can achieve that remission, but it's kind of hard to achieve. Okay, because of some comorbidities that they might have. Maybe they have some other health issues that may complicate the therapy, and so that would really be challenging, especially. Now, this is also going to require much more aggressive treatment, and so we know that these anti-cancer medications can be also toxic, which will really complicate things. And as far as the prognosis, it is considered as very poor or poor in the older adults. Okay, now don't forget about the AML. This is occurring in the adults, especially the elderly, I should say. Now, let's talk about the ALL, or the type of acute leukemia that actually would affect more in children, right? And so what is this? This is something that can originate in the lymphoid progenitor cells in the bone marrow as well. So look into the comparison. This is lymphoid, whereas this one right here, it's coming from the myeloid progenitor cells. Now, let's talk about the incidence. Again, like I said, it occurs more in children, but can also occur in adults, but primarily you will see the cases in children more often. Now, for the risk factors, what do you think can contribute to the ALL? Well, this is going to be contributed by the predisposition, genetic predisposition. It could be previous chemotherapy, or it could be radiation, or it could be viral infections, maybe the Epstein-Barr virus or the EBV. So that's another one right here. Right? Now, how are they going to be responsive to the therapy? Are they going to have some remission when they get the chemo? Most often, children will have more of the remission. Okay, they are more responsive to the chemotherapy. And again, they have less complications, less known medical history. And so there will be a few challenges as far as with the chemotherapeutic agents. Now, with the prognosis, it's known that in children, they will have higher prognosis or long-term survival rates. So that is a good sign, right? So again, just kind of looking into the differences between the two, I would remind myself, if I'm reviewing this concept, I would think about the AML as something that would occur more in adults, whereas the ALL will occur more in children. As simple as that. And the prognosis is a whole lot better in children compared to the adults. And there is much more remission in children because of the lack of other comorbidities. They have less health issues, and so they're going to have more of the remission. Now, let's talk about the clinical manifestations here about the acute leukemia. So in general, guys, we will be seeing anemia in our patients. So this is one of the top manifestation. And again, the reason for that, it's because of the proliferation of the abnormal cells in the bone marrow. It will have a dysfunction in the production of the red blood cells. So what do you think can happen to our patient with the anemia? Of course, well, I think you already know the answer to that. You will immediately think that, yeah, the patient will have some issues with their oxygenation. They're going to end up with a dyspnea. There's going to be problems with their integumentary system. They're going to be pallor, jaundice, possibly. There's some exhaustion. And so these are things that you will be expecting in this patient. Now, aside from the dyspnea, there's also possibly some changes in their anatomical structure, right? Especially for the children. They're going to have some stunted growth because of the poor oxygenation. So we're going to add to that, to the anemia manifestation. Now, let's talk about their increased risk to developing infections. Again, because of what? The neutropenia. Decreased white blood cell production. So they're going to be susceptible to getting all those opportunistic infections. So our patient will be prone to getting the usual pneumonia, urinary tract infections, and also pharyngitis, especially in children. They're prone to developing the common infections and possibly esophagitis. And they're considered to be severe and can lead to much more life-threatening complications because of their compromised immune function. So don't forget about the different complications that they can develop when they have these drop in the blood counts. Now, let's take a look into the thrombocytopenia. You have already an idea, right? What can happen when there is a person when a person develops low platelet count? Of course, we are going to expect some bleeding, right? Especially with the epistaxis, even with just slight irritation into the nasal mucosa when they're removing the booger or any of those dirt from their nose, they can easily develop, or they will end up with the nose bleeding. Okay. Another is when a patient will be having a venipuncture or maybe a minor cut, there's going to be increased or prolonged bleeding whenever there is that paper cut maybe. And you will also notice that petechiae, those tiny, small red spots on the skin. Petechiae, or it could be the purpura, which are actually larger, and they are going to represent more of like bruise. There's also ecchymosis, and it can involve a wider area in the skin. And again, they're going to be developing some more of the bleeding tendency. Even with a slight bump on a hard surface, maybe a door, they can get those bruises so easily. Okay, so don't forget about the anemia, their risk to getting the infections easily, and also their risk of prolonged bleeding. Okay. Now, another clinical manifestation here is the splenomegaly, enlargement of the spleen. Why? The reason for that is because of the infiltration of the leukemic cells into the spleen. Okay, infiltration of leukemia cells in the spleen. Same thing with the liver. The leukemia cells will also infiltrate into the liver. It will get bigger. It will be enlarged, inflamed. And also, the lymph nodes will also grow bigger, and this is caused by the infiltration as well. Excuse me for a second. I just had that quick itch in my mouth taken. Ugh. I'm almost ready to cough. This is the dry cough I get with ACE inhibitor. Excuse me. All right. Ooh, just came out of nowhere. Now let's talk about the lymphadenopathy. This is something that can be assessed, especially when the size of the lymph nodes become bigger. It goes bigger than 1 centimeter in size. They are going to be palpable, guys. So don't forget about those sites where you can actually palpate those supraclavicular, submandibular. So don't forget those regional sites that you should be assessing in this patient. Now, another manifestation is the bone and joint pain. The patient will have the pain sensation, and again, this is caused by the infiltration, the invasion of the leukemia cells into the bone marrow. Talking about invasion of the leukemia cells in the bone marrow, and that's why they're going to end up with bone pain, and also the periosteum. So which is basically the outer layer of the bone. So yeah, don't ignore this manifestation. This is going to happen because of that invasion into the bone marrow itself. Now, in our patient, they're also going to manifest some diffuse or focal neurological dysfunction. And so what you're going to see in this patient, especially if there is already infiltration of the leukemia cells into the central nervous system, they're going to end up with the meningitis. Let me put this away. They're going to have meningitis. And also, they're going to end up with seizures. This simply means that the leukemia cells have infiltrated gravely into the structures inside the brain. Now, for the children, they're going to have the testicular involvement for the boys. We have the ALL here. So the reason for that, again, is the infiltration of the leukemia cells into the testicle. This can cause the enlargement and also pain into their testicles, scrotum. And yeah, not going to be fun for them, right? Another thing is that this can also lead to an anterior mediastinal mass, which is going to occur in the ALL type. So this will really can cause some discomfort into their chest, can compromise their breathing as well. And this is caused by the accumulation of the thymus gland type of leukemia cells. Okay, so this is why we call it the T cell ALL. There is what we call as the presence of the mass in the front part of the chest because of the leukemia cells accumulating in the thymus gland. All right, so there is that mass formation. Now there's also skin nodule, which will be assessed. So there is going to be presence of the bumps. When you are doing an overview assessment of your patient, you can see the nodules directly. Now let's talk about the diagnostic tools that will be able to help in the diagnosis of the leukemia, acute leukemia, I should say. Well, as we have noticed that there is going to be an effect on the white blood cells. And so guys, this is going to be quite tricky. Now, don't get confused here, because with a white blood cell count, it can be either leukopenia versus leukocytosis. Well, it can be reduced, right? Maybe just 1,000 per cubic millimeter, or it could reach up to 100,000. And the reason for that elevation, if there is a total elevation of the white blood cell count, even though that we're talking about what do you call this, leukopenia or leukocytosis, there is still a significant amount of the blast cells, which are the immature types of cells that can really congregate in the circulation, and that is why there is going to be that elevation. Okay, leukocytosis basically means that there is a lack of the mature white blood cells circulating. That is why there is, leukopenia rather. So leukopenia, which is going to be that low white blood cell count. Again, this pertains to the low mature white blood cells, whereas our 100,000 per cubic millimeter is caused by the elevation, or the accumulation of the immature blood cells, the white blood cells, I should say. Now, let's talk about the peripheral smear, or actually the red blood cell. So this can be detected right away. The patient will end up with low hemoglobin, low hematocrit, low red blood cell count. And again, you will expect that the patient will end up with the pallor, easy fatigability, poor oxygenation, easily exhausted. They cannot tolerate any regular physical activities, and also stunting of their growth, especially with the children. Now, with the platelets, let's talk about the thrombocytopenia. Of course, our platelet counts here will be greatly reduced, right? Less than 150,000 per cubic millimeter rather. And so our patient here would be prone to bleeding. They're going to end up with so many bruises, ecchymosis, hematoma, purpura, and the petechiae. Now, let's talk about the electrolyte imbalances. Why do you think that our patient might end up with the electrolyte imbalances? Well, the reason for that is because in the acute leukemia, there is going to be a fast turnover and also breakdown of the leukemia cells. Okay, increased breakdown and turnover of leukemia cells. And so what are these disturbances that can be seen in the laboratory? Well, let me check. Let me see if I have that. Yeah, hyperuricemia is one, even though it's not really an electrolyte, but that is just like included in this section. Okay, so when there is an increased turnover or maybe cell death of the leukemia cell, this can lead to the buildup of the uric acid coming from those dead leukemia cells. And so this will now be increased in the bloodstream. So our patient here will be prone to developing what? Hyperuricemia, because of that rapid breakdown of the leukemia cells. Another is the hyperkalemia, which is the elevation of the potassium. This is going to be a medical emergency, especially if the patient's potassium level is skyrocketing. Could be greater than 6 milliequivalents per liter, maybe 9. And again, this is caused by the cell lysis, the breakdown of the leukemia cells, and will be more aggravated when we are treating this patient with chemo. When we are treating them with those anti-neoplastic medications, it will kill those cancer cells, right? But along with that, it can release the potassium ions from the cell, and this will accumulate in the bloodstream. So our patient is at risk to developing those cardiac dysrhythmias because of the hyperkalemia. Now, talking about another imbalance is the hyperphosphatemia. Well, the reason for that, it's because of the rapid cell turnover. Rapid growth and rapid death of the leukemia cells. This can lead to the accumulation of the phosphorus inside the bloodstream. Now, as we know that phosphorus and calcium are like big enemies, right? So whenever there is an increase in the phosphorus, what you're going to expect here is that the patient will end up with hypocalcemia. Now, let us talk about another diagnostic test. Basically, what we have here is the bone marrow biopsy. So what is this? This is going to be required for the diagnosis. This will give the definitive diagnosis for this condition. Definitive diagnosis. So those white blood cell, red blood cell, platelet dysfunction are just supportive lab data, okay? But we are going to rely on this information. The result of the bone marrow biopsy will be our main source for the diagnosis, okay? So this will involve the extraction of the bone marrow tissue, and most specifically, this is going to be done in a very strict sterile environment, and the patient will be harvested, typically from the iliac crest, okay? So the bone marrow biopsy will be done mostly in the hip bone, in strict sterile condition, all right? Now, when we are looking into the result of the bone marrow biopsy, if we are going to expect a patient with an ALL, what do you think can be found in the result if it is the acute lymphocytic leukemia? Well, this will show proliferation of the blast cells. Blast cells of lymphoid lineage. And this is going to be about 20% of the total marrow cells. Okay. Now, if the patient is known to have the AML, what can you see in the result? Well, it will reveal proliferation of the blast cells. And of course, this is going to be of myeloid origin. All right. And this is going to be about 20% of the total marrow cells. So don't forget about the bone marrow biopsy. It will reveal which is really affected. Is it the lymphoid tissue or is it the myeloid tissue? So this will really give us a better understanding what type of acute leukemia the patient have. All right. Now let's also talk about other testing, but let me get rid of this. There's also some genetic testing. I'm sorry, I got that one out. Hang on. So another testing that can be done is to do the immunotyping and also cytogenic analysis. And they can also classify the subtype of the leukemia that the patient may have, and also will help in the treatment decisions. Again, one is the immunophenotyping, and the other one is the cytogenic analysis of the bone marrow cells. Immunophenotyping, and the other one is the cytogenic analysis. So this will determine more of the different subtypes of the leukemia. So this will give us more in detail the subclassification of the leukemia. Now let's talk about the treatment of the acute leukemia. There are so many, guys, so hang tight. You will really need this information before we're going to go to do our exercises. So what would be the different treatments that you should expect in managing this patient with acute leukemia? There are so many. So one of those is the emergency treatment. And you will encounter more often this kind of patient being admitted in the hospital because of a possible infection that they have. They probably have this anemia or maybe thrombocytopenia. And so they're going to be treated with the antibiotics in order to address the infections that they have. And again, because they have compromised immune system, they are prone to developing those opportunistic infections like the pneumonia, urinary tract infections. And so we are going to treat this patient with the anti-infectives. Now, another is the administration of the packed red blood cell. We are going to transfuse them, especially if they are very symptomatic in their anemia, or let's say their hemoglobin counts are very critical. And most often, we're going to have to anticipate administering the blood transfusion, especially if they are less than 7 grams per deciliter, okay? But this is just not the criterion, right? The medical provider will also look into the clinical features of our patient. Is the patient symptomatic severely? And so they're going to decide on ordering the blood transfusion, especially the packed red blood cell. Now, there's also a need for platelet transfusion if there is significant bleeding, okay? This is intended when they have significant bleeding because of what? Thrombocytopenia. How's everyone today? Are you still doing okay? All right, platelet transfusion. We will be giving that whenever there is a great need, especially if they're bleeding out. Now, part of the treatment in acute leukemia is the administration of chemotherapy. So we're gonna be involved in the aggressive chemotherapy, and this is going to be subdivided into different phases. One is the induction therapy. Please pay attention. The induction therapy is what we considered as very intensive, okay? This is intensive. And the goal of the induction therapy is to cause remission. That is the word, cause remission, in order to allow this patient to be symptom-free for a certain time. So this will now reduce the number of the leukemia cells. It can reduce the amount of leukemia cells. Again, guys, we are talking about induction therapy, which is very intensive. So this can last for several weeks in order to achieve this remission. It's not going to be easy for this patient because along with the treatment, they're going to manifest so many side effects of the drug as well. And this is something that we really need to have a deep conversation, especially with the medical provider and the patient and their family, making sure that they understand the goal of the therapy, which is basically to reduce the amount of the leukemia cells in the bone marrow and the blood. Okay. And when the patient has the induction therapy, especially if we are talking about the AML for the adults mostly, right? For the adults, what we're going to expect here are the following medications. One of those is the daunorubicin, okay? Daunorubicin, or could be the other one, which is the idarubicin. These are highly toxic medications, highly toxic to the leukemia cells, but also toxic to the body cells. And this is going to be combined with another medication known as the cytarabine. Okay, so I'm just mentioning the names here. I'm not gonna really emphasize the in-depth the description. We're gonna talk more of this in the next chapter, right? And so with the AML, these are again the medication, the daunorubicin, the idarubicin, and the cytarabine. Now for the pediatric patient or those with the ALL, this is going to be based on, the chemotherapy is going to be based on the factors, especially the age. And most often this is going to employ the use of the vincristine, which is the vinca alkaloid type of anti-cancer medication. There's also going to be a need to use the corticosteroids, prednisone, and also the anthracycline. So this is going to be so complex. There are so many medications involved. And again, the goal of the induction is to what? Reduce the proliferating leukemia cells in the bone marrow and the bloodstream. So this is the goal. It is very intensive. Yeah. Now let's talk about another phase in the chemotherapy. Let me erase this one. Aside from the induction, there's also what we call as the consolidation therapy. Now, what is this? This is going to follow the induction therapy. So this will be the succeeding treatment. After the patient completes the induction therapy, they're going to require this. And the reason for the consolidation therapy is that it will eliminate the remaining leukemia cells. Eliminates the remaining leukemia cells. And it will also help in reducing the risk of the relapse. Reduces relapse. So that's the reason why a consolidation therapy will follow after the induction. And so the patient here will get many cycles of a chemo. They're also going to have some other stuff like targeted therapy. Now, talking about the targeted therapy, which is basically going to involve the use of the tyrosine kinase inhibitors, or the TKIs. Let me erase this. So these are the following medications that are known. We have the imatinib and also the dasatinib. So these are your medications representing the targeted therapy with a classification of the TKIs. We call them as the tyrosine kinase inhibitors. So what is the mode of action of the TKIs? Well, it will stop. It will inhibit specific pathways. Pathways that actually can promote the leukemia cell growth. So it will stop specific pathways that promote leukemia cell growth. So once this medication is administered to the patient, so what to expect? There's going to be no growth of those leukemia cells. Okay? It will stop the growth of the leukemia cells. So think about the TKIs. Another treatment is the use of the monoclonal antibodies. So this is represented by the drug rituximab, which is very popular. And The reason that this is going to be effective is that it will target the specific surface marker. Again, it will target the surface marker known as the CD20. Okay, it will target that marker. Now, how is this medication administered? This is administered intravenously. It could last for several hours or a few hours. And taking into consideration the side effect of the rituximab, most of the reactions that you will expect is the fever, there will be chills, and also nausea. And they can also be fatigue and a risk of getting opportunistic infection as well. And so we definitely need to keep an eye into the responses of the patient, make sure that we are managing them appropriately in order that we can prevent those complications, right? And we're also going to talk about the stem cell. Actually, there's another one, which is the FLT3 inhibitors. And this is going to be indicated for the acute or the AML for the adults. So what is this? This is going to direct against the specific genetic mutations of the leukemia cell. So this is what we have here, the FLT3, which is very specific to the kind of mutation. So we have them in the list as well, but not quite common. Now we have the stem cell transplantation. So what is this management? Well, we have already included this in our discussion yesterday, right, about the stem cell. So basically the patient with the stem cell transplantation, or the SCT, stem cell transplantation, the patient will end up with a replacement. So there is going to be replacement of the diseased bone marrow. Again, this is a very strict procedure, will require high sterile environment. And again, the reason for this procedure is to replace the diseased bone marrow with healthier stem cells. Maybe the patient had already some good stem cells that were harvested prior to the leukemia, or maybe it can be harvested from a compatible donor. Okay, so we have the stem cell transplantation. It can be what? Allogenic, or it could be autologous. If we are talking about autologous stem cell transplantation, the medical provider will be using the patient's own stem cells, which were collected before the intensive chemotherapy. Now, when the patient had completed the high-dose treatment, then the stem cells will be returned to the patient and will be helpful in regenerating the bone marrow, I should say. Okay, but in reality, it's less commonly used in acute leukemias due to the risk of the relapse. Okay, less commonly used, even though the idea is very good. But again, in reality, it is less used because of the risk of the relapse. Now, the more common one is the allogenic, wherein the person has a designated donor, wherein the donor will be, of course, have the healthy bone marrow cells. And of course, it can be a family member, sibling, or maybe an unrelated donor. And this will give the leukemia patient with much more, or let's say healthier immune and blood forming cells. Okay, so don't forget about the allogenic and the autologous. Okay, so that is about the stem cell transplant. Now, talking about the complications of the chemotherapy, this is the real deal, and things would really get so ugly especially during the chemotherapy or after the chemotherapy. There are so many complications that we are going to anticipate happening, okay? The complications will occur no matter what. And so we're going to identify those severe complications first. So what are these severe complications? Well, top of that will be the bone marrow suppression. Now, before we're going to talk about the bone marrow, we'll just deal with that. With the bone marrow suppressions, of course, the production of the neutrophils, the white blood cells, will be compromised, okay? So there's going to be drop in the white blood cell count, and there's also going to be a drop in the neutrophil count. So I don't know if you're familiar with the absolute neutrophil count. ANC stands for absolute neutrophil count. So this is basically what we are going to base on if we are suspecting that the patient may have neutropenia, okay? So this is going to be shown in several ways. We're going to have to identify maybe the what do you call this? Neutropenia is mild, or it could be moderate, or it could be severe. Now, when there is neutropenia, this can really increase the patient to developing the life-threatening infections, right? So let me just put it here. Decreased ANC, there is going to be increased risk of infection. All right? Again, if there is a drop in the absolute neutrophil count, the patient is at risk to developing those opportunistic infections. Now, we will classify this according to the severity, okay? It is considered mild neutropenia if the person's ANC is somewhere between 1,000 to 1,500 cells per microliter, okay? That is considered mild neutropenia. When we are going to encounter a patient that may have a moderate neutropenia, what do you think would be the value here? Their value will be between 500 to about 1,000 cells per microliter. Okay? Now, moving forward here, the severe neutropenia. The value here is much more compromised. It will be less than 500 cells per microliter. And as we know that the neutrophils are basically the critical white blood cells that will defend the body against the bacterial infections, could be fungal infections. And again, with the chemotherapy, this can deplete the neutrophils. It can weaken the immune system, and it will make the person much more susceptible to the opportunistic infection. Now, let's take a look here about the calculation. I don't know if you know this in the past, but having worked in the oncology floor as well, this is what we do in order to determine the absolute neutrophil count. So, how are we going to calculate the ANC? We're going to calculate that by identifying first the amount of the white blood cells, okay? And then we're going to have to multiply it by the constant of 60 over 100, okay? So this is how we're going to calculate the ANC, if in case it comes out in the exam. We're going to have to determine first the value of the white blood cell count. And then we have a constant of 60 divided by 100. So, for example, if the patient's white blood cell count is about 8,000, and we have the constant 60, right? Over 100. So what do you think about that? So that will be 8,000. You multiply it by the 0.6. So it will yield about 4,800 cells per microliter. So this is how we determine how high or low the absolute neutrophil count is. Okay, again, this is our basis about determining whether the patient is in a severe form of neutropenia, or are they in a moderate form of neutropenia, or are they mildly neutropenic. So don't forget about that. Okay, now talking about, let me just remove that. So many things on the wall. We're going to talk about the interventions, especially when the patient has neutropenia. So what do you think we will do for this patient with infection? Well, our management here will be the administration of prophylactic antibiotics, they're going to require admission to the hospital, guys. And the reason that we're going to have to give the prophylactic antibiotics is to prevent the bacterial infections. And we're also going to place the patient in neutropenic precaution. Neutropenic precaution. So I'm sure you probably have known those interventions. We're going to have to implement strict infection control measures. We're not just going to allow anybody to get inside the patient's room without screening them. Make sure that they are not carrying any diseases. They're not infected. Make sure that they are wearing the proper PPE. They should not be getting or not bringing any fresh fruits, no vegetables, or let's say uncooked food items. They're supposed to leave them outside the patient's doorway. Okay, so that's part of the neutropenic precaution. Now, another thing in the treatment of the neutropenia, what do you think can be added? No raw vegetables, no flowers. Okay. We're also gonna administer them this medication we call as the granulocyte colony stimulating factor. Okay, remember about this medication? Granulocyte colony stimulating factor. And yeah, this is shortened as the GCSF, right? And the very popular medication we have studied is the filgrastim. Okay, filgrastim. Again, that is filgrastim. So what is the drug action of the filgrastim? This can stimulate the neutrophil production. Stimulates neutrophil production. So it will boost the production of the neutrophil, and this is going to be administered, and the dose, the frequency of the medication will be dependent on the severity of the neutropenia. Okay, so the administration again will be the route, rather, it will be given as a subcutaneous injection. Subcutaneous route. Okay. And the goal here is to what? Boost ANC. Okay. And we want to make sure that the neutrophil counts as well will be increased up until the neutrophil count will reach 1,500 cells per cubic millimeter. Okay, don't get confused. I'm talking about neutrophil. ANC is another value. Okay, so our injection, our administration of the filgrastim will be continuous up until the patient will reach the neutrophil count of about 1,500 cells per cubic millimeter. All right, and so the calculation of the ANC will also be done along with that. Now, what are we going to do about the thrombocytopenias? We're going to go along with another problem in, oh, there you go. I don't know that I have those already. So whenever our patient has the thrombocytopenia, what do you think should be performed by the nurse, or what intervention should be provided to this patient whenever they have thrombocytopenia? I want to see what your answers are. So if you could kindly type in your answer in the chat box. Well, we're going to definitely need to administer some platelet transfusions, right? If required, if prescribed by the medical provider, we're going to have to administer platelet transfusions as prescribed. And again, this is to prevent the patient from bleeding. And aside from the administration of platelet, we're going to have to avoid invasive procedure. Avoid performing unnecessary invasive procedures. Yeah, this can be challenging, guys, especially if we're going to monitor the patient's blood counts more frequently. And the patient will really require blood draw, venipuncture. And so it would be nice if the patient has a central line, a PICC line maybe, that will really prevent frequent venipunctures that could really cause undue bleeding for the patient. Okay. And also we're going to have to do our diligent assessment, which should be the topmost here. I just forgot to put it on top. But our assessment here is to look for those signs of bleeding. We want to make sure that our patient is instructed about their limitations, that they're not supposed to be using the straight razor anymore. They're not supposed to do a lot of the dental flossing, and they need to make sure to use a soft bristled brush, especially with oral care, because they are prone to the gum bleeding. Now, as we are talking about another problem here, as a complication to the chemotherapy, is the anemia. What do you think should be the cluster of interventions in the person with anemia? Well, what we're going to also do is to administer packed red blood cell transfusion as needed and as ordered. So I'm going to put right here, symptomatic anemia, or if the hemoglobin is less than 7 grams. I'm still torn between the use of a GM and the G. 7 grams per DL. Okay, so our patient will possibly require the packed red blood cell transfusion. And this is really to boost the amount of hemoglobin circulating in their bloodstream, or else they're going to end up with hypoxemia, right? If they don't have the adequate amount of the hemoglobin circulating in the bloodstream, of course, our body system, their body system, will be deprived of getting that adequate nutrition and also the oxygen. Okay. Now, another treatment to deal the anemia of the patient will be the what? The administration of the erythropoiesis stimulating agents. Erythropoiesis, stimulating agent. And I think you already know the name of this medication, guys. So they can definitely stimulate the production of the red blood cells, and this is going to be administered as a what? Subcutaneous. Do you remember about the Procrit? Okay, injections. So this will also boost the red blood cell production. Okay. Now, talking about another complication here, guys. This is a common problem that can happen in a patient undergoing chemotherapy. We call this as the TLS, tumor lysis syndrome. So what is this? This is going to happen when the chemotherapeutic drugs can rapidly kill those leukemia cells, right? Again, it can kill the leukemia cells, but with that, it can release the contents. The contents inside the leukemia cells will be released into the bloodstream. Release of leukemia cells content in the bloodstream. All right. As soon as the chemotherapeutic agent kills the leukemia cells or the cancer cells, it will lead to the spread of those cellular contents from the cancer cell. It will increase in the bloodstream. So what can happen here? Well, there's going to be hyperkalemia. That is one, increase in the potassium. There's also going to be hyperphosphatemia, and I believe I already talked about this earlier, increase in the phosphorus. There's also hyperuricemia. The uric acid will also be elevated in the bloodstream, and the patient will end up with hypocalcemia. Again, guys, don't forget about the elevated potassium, elevated phosphorus. There's going to be elevation of the uric acid, and the patient will also have hypocalcemia. Now, I want to know, just based on your judgment right now, what do you think we should be doing to combat or to counteract the tumor lysis syndrome for our patient? What do you think would be the critical nursing interventions that we will be doing, either dependent or independent nursing? What do you think would help this patient? Well, we know that hyperkalemia is going to be deadly. It can cause dysrhythmias. Hyperuricemia can also lead to the kidney stones, uric stones. Hyperphosphatemia also with the hypocalcemia. What do you think? Well, our management for the tumor lysis syndrome is topmost is hydration. Do not forget about hydration. It is in a form of IV fluids. The oral form we can encourage, but will not be sufficient. So we're going to administer IV fluids. And the goal is to cause diuresis. This is what we want for our patient. And this will flush out the excess uric acid and also excess phosphorus. And we're also going to flush the excess potassium. Okay? Because if we are not going to do this, the excesses that we have encountered can cause kidney damage. And this is what we want in this patient. We're going to hydrate them with IV fluids in order to prevent kidney damage. Yes, also reducing the potassium intake would be helpful as well. So, prevent kidney damage. So what we're going to do on top of the hydration here is to restrict K, also rich in phosphorus medication. We're going to do that. All right. And for those items that are rich in uric acid, we're going to have to restrict those as well. So this is going to be somewhat kind of temporary, as this is associated with the chemotherapy. Okay, but when the patient is in that duration where they're getting the cycles, definitely there is a form of restriction from these food items in order to prevent the elevation of these substances: the potassium, the uric acid, and the phosphorus. Okay. Now, another intervention aside from the hydration and also the restriction of the potassium will be what? We're going to deal with the uric acid by administering allopurinol. Okay, so this will lower the uric acid. We're gonna anticipate administering the allopurinol. Again, this is intended to decrease the uric acid to prevent kidney damage. Okay, now we're also going to monitor the patient's electrolyte, fluid electrolyte. I'll just shorten that as F&E. Fluid electrolyte monitoring is very important, as we know that hypo or hyperphosphatemia, and there is also hypocalcemia, and there is hyperkalemia. So we want to make sure that we are looking into the laboratory reports and report them right away if they're significantly imbalanced. Okay. Aside from the fluid electrolyte monitoring, we're also going to assess for the renal function. Renal function, as we know that the exit point of these substances is the kidney. All right. Yeah. The kidneys are the main exit points of these substances. And so we want to make sure that we are going to assess and monitor the patient's kidney function in order to detect any impairment. Okay. All right. That's already a lot of interventions right there. Now, what else are we going to continuous telemetry monitoring if there is already known dysrhythmias that had occurred into our patient? Yeah, we will include that as well. Cardiac monitoring, if this is already known to our patient, if there is a significant imbalance in the calcium and also the potassium, cardiac monitoring is important. Of course, our strict hand washing, don't neglect that. So many things that we can do for this patient. We will be running out of space here. Now, talking about other manifestations or complications of chemotherapy, let me erase this. Let's talk about gastrointestinal manifestations. Yeah, I guess you already know what these manifestations, right? Well, we have the NV, nausea, vomiting. These are common side effects of the chemotherapy because of its effect in the GI tract's lining. And also, the chemotherapeutic agents can also trigger the chemoreceptor trigger zone. Chemoreceptor trigger zone. Do you remember about this when you're looking into the drug handbook? Chemoreceptor trigger zone. This is it. This is going to be stimulated by the chemotherapeutic agents. That is why our patient will end up with the nausea and vomiting. Well, what are we going to do to deal with the usual nausea and vomiting? Well, we've already talked about this yesterday, right? About the administration of the anti-emetic medications. Yeah. Administer anti-emetic meds. So this is going to be given prophylactically. We're not gonna wait for this patient, hey, I just want you to vomit right now so I can give you the nausea medication. No, we're going to administer the anti-emetic medications way before they're gonna end up with the nausea. That's why it's called prophylactic, in order to control the complications, the loss of fluids, the loss of electrolytes. We want to make sure that this is going to be given as scheduled. Another is going to include dietary modification. When I'm talking about dietary modification, what do you think would be included here? Well, our patient will be prone to the nausea, and so we're going to offer them small, frequent meals. All right. And also avoiding those foods that have strong odors. Avoid strong odors. So maybe around this time, if the patient was used to taking a lot of the spices, other condiments, maybe this time they have now alteration in their sense of smell and sense of taste. And so this can also add to the nausea if they're going to be exposed to the strong odors. And so make sure that we're going to avoid those unnecessary factors, or let's say causes that could lead them to having the nausea. Okay. Now another is to promote hydration, which is very important, guys. Let me put it right here. Hydration, in order that our patient will have adequate amounts of fluid circulating. Okay. And of course, prevent dehydration. Simple as that. Now, and I think we have already talked about another complication in our past test item. Another is mucositis. Oh, there's more than that. So mucositis is another problem. Remember about the inflammation of the oral cavity? This was one of the test items that we had yesterday. We're going to treat our patient with the use of the saline gargle. That was one of the nursing recommendation, saline gargle, which will decrease the inflammation inside the mouth. Another is the use of the prescribed topical anesthetic agent. Topical anesthetic agent. Okay, let me clear this out here because it's getting confusing. Okay, let's talk about mucositis. So one of the interventions that we had was saline gargle, and we're also going to administer topical anesthetic agent. So this is going to be done as an oral rinse. Going to be an oral rinse, and this has the numbing effect into the oral cavity. It will relieve the pain. It will relieve the discomfort. Guys, have you encountered administering the medication like the viscous lidocaine in the medical surgical floor? Are you familiar with this medication? Viscous lidocaine. It comes in a cup, and this is something that will be used by the patient to swish around their mouth to promote pain relief. It will cause numbing of those very sensitive areas inside the mouth. The viscous lidocaine will be gargled, or let's say swished around the mouth to promote comfort. All right. Now, aside from the topical anesthetic agent, we're also going to have to offer soft food. And I think this also came out in one of our tests the other day. Soft foods, especially for those patients now with the aversion to take anything by mouth because it's just so painful. And they're going to end up with weight loss. Yeah, I think I remember this one. That patient that had a 5-pound weight loss over a course of 2 weeks. And so we're going to have to offer them soft foods that can be easily swallowed, avoiding spicy food. What else? Anything that can irritate the oral mucosa will be avoided this time. All right. Now, also, we need to collaborate with the dietitian, nutritionist. Okay, collaborate with dietitian, nutritionist, in order that they can prescribe those appropriate diets for this patient that had impaired nutrition. Now, we're also going to talk about other organ toxicities, and this will, the chemotherapeutic agents can also lead problems to the heart muscle, the heart tissue, and also the liver. And we really need to monitor our patient. We have to check the cardiac function with echocardiograms. So let me put it right here. Heart. We're going to have to do the scheduling echocardiogram to check for the cardiac function. And also we're going to have to check the patient's liver function test, LFTs. And this is going to determine if there's already toxicity in the liver, right? Now, back to the heart here. What do you think with that medication that has that cardioprotective effect? So we have a known medications like dexrazoxane. Are you familiar with this drug? Dexrazoxane. Tongue twister. It has a cardioprotective effect against the chemotherapeutic drugs. Dexrazoxane. Another tongue twister. Now, for the liver toxicity, we are going to again monitor the liver function test, the AST, ALT, the bilirubin, AST, ALT, the bilirubin. And this is going to be done periodically and regularly in order for us to capture those elevations. Now, we're going to talk about other complications in chemotherapy. Yeah, there's more in the list, guys. It's somewhat kind of endless. The neuro manifestations, including the peripheral neuropathy. The chemo medications can lead to the peripheral neuropathy, and so we're going to expect the weird sensations. There will be numbness, tingling sensation, pins and needles. And these are painful, guys. This patient will not be able to sleep well because of the abnormal sensations in their legs and their feet. And again, this is caused by the damage of the peripheral nerves by the chemotherapeutic agent. So what are we going to do for this patient with a peripheral neuropathy? Well, we're going to deal with, we're going to have to administer medications that will target neuropathic pain. Pain meds that will alleviate the peripheral neuropathy. Another is the collaboration with the physical therapy. This is important, guys, because when the patient will end up with the peripheral neuropathy, this can also lead them to having abnormal gaits, balance problems, and so they're going to be risk to having falls. Physical therapy will be helpful in preventing those risks of falls. The patient will be able to maintain nerve function. Whatever is left, the physical therapy will enable them to strengthen their muscles and prevent the occurrences such as falls. Now, talking about another side effect here or complication is the hair loss. Yeah, it's kind of sad. They're going to end up with alopecia. So it will become somewhat temporary. And for some patients, it can be permanent as well. And one of the treatments for the hair loss is basically what we call as scalp cooling. Are you familiar with scalp cooling? This is going to include the use or involve the use of cold caps or, let's say, cooling devices that will be applied to the head during the infusion of the chemo drug in order to prevent the hair loss. Another is the use of the wigs. This is very common in the NCLEX, or head coverings, right? Wigs, head coverings, these are just supportive measures in order to help the patients cope with their changes in the appearance. Altered body appearance is a huge thing, guys. It is. And so you need to deal with that as well. Now, another complication to chemotherapy is the fatigue. There's also depression. There's so many things. And with the fatigue, uh, the patient will get easily tired. There's a lack of energy. This can really impact in doing their daily activities. And so what we need to do here for this patient is to conserve their energy. We're going to have to promote rest periods. Promote rest periods. And I'm sure you're probably thinking about the test item that we had yesterday about a patient that had insomnia, right? Probably so. Promote rest periods. Who are still thinking about the test item about the insomnia? Promote rest periods, and this will really combat the fatigue. Okay? Now, another is prioritizing activity. So if the patient doesn't if it's not necessary for this patient to do this kind of activity, then don't let them do it. It will just cause more fatigue. Now, even so, if they have fatigue, we still need to maintain some form of physical activity. It doesn't mean that we're just going to let them be in their bedroom. Yeah, just let them sleep 24/7. No, just kidding. We need to give them some form of physical exercise. So gentle exercise will also be afforded. We need to at least allow them to get out of bed, do their usual toileting, ambulating to the bathroom. As long as they're safe to do it, let them do it. Okay? You got to also evaluate, assess the safety level of our patient. Are they able to tolerate going to the bathroom? Yeah, you have to assess that as well. So gentle exercise is definitely going to help in allowing some form of activity in our patient. And also, it will at least give them a sense of independence as well. That, hey, I can still do this kind of physical activity. I'm just not bedridden. I can do some stuff myself. So let them do that as well. Now, emotional distress is a huge thing in chemotherapy. And so one of those is the anxiety, depression. Why are you talking about these stuff? I thought that we're just talking about leukemia. Yeah, we're talking about chemo, and that's why you need to know these things. Anxiety, depression, mood disorders, they can be quite unstable around this time. And so we need to do some thorough assessment of our patient's psychological state. We need to make sure that they are able to verbalize what they have. Are they quite depressed with their condition? Maybe the chemotherapy is adding to that as well. And it is very helpful if we're going to recommend some counseling. And also make sure that there are going to be some recommendation for some therapy in order that they can, the person that is involved here can address the emotional challenges that we can't. All right. I know that we can deal with these things, but you just can't do everything in your shift. You will be overwhelmed if you're not going to ask for assistance from other healthcare team members. So make sure that you're going to involve the others in helping this patient out. Aside from the counseling therapy, maybe the medical provider will also prescribe antidepressant medications, which will be helpful for the patient, or maybe anti-anxiety medications. Antidepressants, anti-anxiety medications. And again, this can also lead to the insomnia, depression, anxiety. Yeah, they can go hand in hand. And so expect the patient to have all these clusters. Now let's talk about the chronic lymphocytic leukemia, or known as the CLL. So what is this? This is going to be prevalent in the adults, especially older than 50 years old, and mostly occurring in Western world. And the median age, or the specific age, or really the median age, is usually around the mid-50s, or let's say around 60s. And the cause of the chronic lymphocytic leukemia is the abnormal proliferation of the mature. Okay, so here it is the proliferation of the mature but dysfunctional lymphocytes. Earlier, when we talked about the acute leukemia, there is abnormal proliferation of the blasts, the immature cells. But here in CLL, there is abnormal proliferation of the mature but dysfunctional lymphocytes. And as far as the aggressiveness, what do you think about the aggressiveness of the disease process? Well, this is known to be progressive, slow, progressive in nature, and the patient will succumb to other causes rather than the chronic lymphocytic leukemia type. And this is also going to manifest so many things, guys. And the clinical manifestations are quite similar with what we talked about earlier about the acute lymphocytic or acute leukemia. And this will include maybe in the early phase. The patient will also have some absence of the manifestations during the early phase. However, once the disease progresses, this can now lead to the development of lymphadenopathy, which is going to be painless. Most often, this is going to be detected in the neck area. Okay, please take note. This is the top manifestation of the CLL. It's going to be detected as painless lymph node swelling in the neck. Another is going to be the enlargement of the liver, the enlargement of the spleen. And again, this is caused by the infiltration of the leukemia cells into these organs. It can also cause the patient to be susceptible in getting respiratory and skin infections. All right. Now, our patient in the advanced stage, they are going to manifest some easy fatigability, weight loss. There's also going to be pallor, bruising, and some bone discomfort and pain. So these are the things that you're going to see in this patient with a CLL. Now, let's go into the diagnostic tests. What are those diagnostic tests? Well, here, the white blood cell count will be elevated, typically about 50,000 to 200,000 white blood cells. Okay. Again, this is caused by the proliferation of the abnormal but dysfunctional white blood cell. I mean, mature. Did I say normal? Proliferation, let me clarify, proliferation of mature but dysfunctional white blood cells. All right. And aside from the elevation of the white blood cells, there's also anemia. Remember about the infiltration of the leukemia cells into the bone marrow. They also will manifest the thrombocytopenia. They're going to be prone to bleeding as well. Another testing is the peripheral blood smear, which will show the absolute production of the mature but dysfunctional white blood cells, right? So it will be shown in the peripheral smear. This is what we refer to as fragile leukemic cells. They're very delicate. They're not really as tough as the regular white blood cells. So this is what we call as fragile leukemic cells. Now, another testing is what we call as the flow cytometry, so which is going to identify a clonal population of the B cells, and this is going to confirm the diagnosis. Confirms diagnosis. Again, this is going to identify a clonal population of the B cells. Population of the B cells, the B lymphocytes, I should say. Now, another testing that will be used is the bone marrow, which is going to what? It can reveal the infiltration of leukemic cells. In the bone marrow. All right. Bone marrow biopsy. Now we're going to talk about the treatment here, guys. What do you think would be the key management? Well, our patient is going to be asymptomatic initially, and the patient should be monitored without immediate treatment. So again, observation, initial, because the patient is asymptomatic. And this is going to be tough because we will only know that the patient has the chronic lymphocytic leukemia if they are tested, right? Let's say, for example, if there was no routine red blood cell check, or let's say no peripheral, or there's no blood smear. And so this would be tough if the patient is not doing any annual examinations, right? Good for those who have periodic testing, let's say annual exams, that they have those complete blood count. But for those who are not really compliant or not even having a medical provider, then the diagnosis will occur later when the person has already the full-blown disease, right? And another treatment here is the administration of the chemotherapeutic agents once the patient is symptomatic, and this is going to be combined with the rituximab and also the fludarabine. And the patient will also require, what else? Do we have, question already? I wasn't ready for that. For the patient that has the symptomatic chronic lymphocytic leukemia, they're going to have to require the combination chemotherapy. We have a brand new attendee, Ruth. Welcome to the class. Yeah, CBC, Melrose, that's correct. Very important to capture the thrombocytopenia, anemia, and the sudden increase in the white blood cell count, the leukocytosis. Okay, now let's talk about the fludarabine. So what is this chemotherapeutic agent? Well, this is a medication that can interferes the DNA, and also interferes the synthesis of the cancer cells. Interferes synthesis of leukemia cells. And this is a very common drug to treat the CLL, guys. So just giving you a hint, the fludarabine is a very common drug that will treat the CLL. So how is this medication administered? This is IV, okay? And the patient will also manifest some side effects. Let's just go directly into the side effects because this is where we're going to get killed in the NCLEX, right? If we don't know the side effects. So common is what? The NV. There's also the D, diarrhea. All right. Fatigue is another one. And the suppression of the bone marrow. Bone marrow suppression. So you know what this is, right? All the blood counts will be decreased. Again, let me remind you, there will be reduced white blood cells, reduced RBCs, and also reduced platelets. So we need to have periodic testing in the patient's complete blood count so we will know if there is also what we call as the nadir, the point where the blood counts are at its lowest, okay? Lowest blood cell counts. So this is where the time when the body will have a very severely low counts, especially with the white blood cells, the red blood cells, and the platelet. This is what we call as nadir. Now, guys, talking about the prognosis of the CLL, well, it can be varied, right? Depending on the extent of the disease and also the presence of the complications and other comorbidities. So if our patient has so many health issues, then it can really complicate the administration of the chemotherapeutic agents. They just probably are not going to be suitable for the chemotherapeutic agents anymore. They just can't tolerate. And so, again, the prognosis can be somewhat on the low end or the low side because of the age in our patient. They are older. Okay. So I hope that you're learning something about from this. Is it short? No, it's not short. It's been an hour and 37 minutes already. So let's get started with our test question, guys. So I hope that you're learning. But again, guys, don't forget to check out our website. We are offering the NCLEX course. This is going to be available for the entire 6 months. When you purchase the program, you will be able to avail updated 3,000 NCLEX questions. We also have upgraded the number of hours for the recorded lectures, and also we have upgraded the number of hours for the animated videos. And on top of that, we still have all those other perks that we have: the audio flip books, the mock testing, the 200 NGN test questions, and I'm sure this is going to be increased in the number of the test questions will also be updated. Now, let's talk about the first question. Where are we at? Question number 1. Drink. First test question. A leukemia patient receiving chemo and experiencing severe anemia is advised to stay in the hospital for blood transfusions. The patient asks about using erythropoietin alpha. What should the nurse respond? Is it A, you could ask your doctor about erythropoietin as an alternative? Good morning, Vinodini, Chandra. Welcome to the class. B, erythropoietin may worsen your leukemia. C, erythropoietin helps extend life for patients with myeloid cancers. And D, you're likely to get erythropoietin along with the transfusion. And I probably did not mention this. We have a question from AGI TV. Please, from which country you're residing or residing? I'm basically here in the Philippines right now. Yeah, I'm back in my home country. All right. So, what is your answer to this test question? Question number 1. A leukemia patient receiving chemo and experiencing severe anemia is advised to stay in the hospital for blood transfusions. The patient asks about the erythropoietin instead. What should the nurse respond? I'm seeing an answer. A, you could ask your doctor about erythropoietin as an alternative. I'm seeing D, you likely get erythropoietin along with the transfusion. I'm also seeing what else? Yeah, D, most often. You'll likely get erythropoietin along with the transfusion. Okay, so let's go back into the scenario here. Our patient is getting chemo with severe anemia and advised to stay in the hospital for the blood transfusions. Yeah, of course, right? This will require frequent monitoring. Our patient will probably have some untoward adverse effects. And the patient is asking about the erythropoietin alpha. What should the nurse respond? So let's screen our answers here. Letter A, you could ask your doctor about erythropoietin as an alternative. Okay. So if you are doing this, you could ask your doctor about erythropoietin. So this is basically suggesting, right? Okay. So this is suggesting. If you're just suggesting, but without providing them the information about the necessary warnings, the possible side effects to the use of this medication, is already misleading. All right? The statement from the nurse is quite incomplete, right? It's just telling the patient, yeah, you can ask your doctor about the erythropoietin as an alternative. You should not just state that one. You should be cautious, especially when you're mentioning a medication. You need to at least give them some information about the possibilities, the side effects, the adverse reaction of the medication. So make sure that you do that. This is a misleading suggestion, okay? You should provide warnings, info regarding side effects, adverse effects. That is going to be much more helpful rather than just telling them a particular medication. Yeah, it will just build curiosity in the patient, but not really having that idea, yeah, I probably would have some complication from this medication. So make sure that you educate your patient about that. Now let's jump off into letter D. You likely get erythropoietin along with that transfusion. What do you think about that? Well, in the real setting, combination of erythropoietin and also with the transfusion is not a common practice in treating leukemia. Okay? Not a common practice in treating leukemia. This is a reality, guys. Doctors are usually not gonna just, hey, yeah, I can order that alpha poietin for this patient, yeah, because they can benefit. No, this is a medication that is also high risk. They're gonna weigh in the risk and the benefits. The patient getting the blood transfusion will be monitored to see if, yeah, maybe the patient will achieve this certain amount or goal in their hemoglobin, then that will be sufficient, right? But not normally going to be a combination of the two, transfusion and erythropoietin. So not going to happen. So we are going to mark that as a wrong answer. What about letter C? Erythropoietin helps extend life for patients with myeloid cancers. So what do you think about that statement? Erythropoietin helps extend life for patients with myeloid cancer. Well, guys, erythropoietin, let me just write that out. Erythropoietin is not known to prolong life. It doesn't. It doesn't. It isn't inaccurate. It's a false reassurance to the patient. It's not known to prolong life in leukemia patients. That is false reassurance. Oops, false. Yeah, there are some contraindications in the administration of the erythropoiesis stimulating agents. Yeah, it's not just like given freely as like lollipops. Even when we are administering it, we really need to make sure that we have a very recent blood tests and also make sure that the patient understands really the therapy, because it has some yeah, please procreate not given if greater than 10 hemoglobin, but if hemoglobin, yeah. But then again, this is not going to be routinely used as a combination in most cases. All right. So what do we have here? Erythropoietin helps extend life. This is what I said as false reassurance. So we have letter B as our last. Let me take a look. Erythropoietin may worsen your leukemia. Isn't that surprising? Hmm. It is surprising. So, what can erythropoietin do? Well, it can stimulate the production of the red blood cells, stimulate production. Let me just shorten that as PRODXN of red blood cells, but can also promote the growth of the leukemia cells. Growth of leukemia cells. I'm just waiting for the explanation. Good that you waited, because I really wanted to make this as a surprise for you, right? Yeah. And so we're going to this is going to something that you need to keep in mind. I know erythropoietin helps in the red blood cells production, but it can also worsen the patient's condition, which is the growth of more leukemia cells. Okay, so here the erythropoietin is basically going to be used as a palliative care rather than as a life-prolonging or curative treatment. Yeah, that's what I said. It's not, this is a false reassurance here, because the medication itself is not used as a curative treatment, but it is only used for palliative care. Yeah. It can help boost the red blood cells. However, it can also worsen the leukemia cells. It can help. I know, there's no denying about it. It can boost the red blood cells. However, it can also worsen the growth of the leukemia cells. All right, there you go. I hope that you are satisfied with the rationale. Let's talk about number 2. A 45-year-old male has been diagnosed with acute myeloid leukemia. Despite multiple cycles of the chemo, his disease has not achieved remission. His oncologist has recommended hematopoietic stem cell transplantation as the next step in his treatment. He is understandably anxious about the procedure and has many questions. As his nurse, you have the responsibility. It is very tricky, guys. It is very tricky, especially with the multiple choice. It is very tricky compared to the next gen. That's why I prefer the next gen, because it's like identification. It's objective. And this one is a lot harder, like the multiple choice. Trust me, they're very hard. So let's talk about this. His oncologist has recommended hematopoietic stem cell transplantation as the next step in his treatment. He is understandably anxious about the procedure and has many questions. As his nurse, you have the responsibility to provide him with comprehensive education about the process, expectations, and post-transplant care. Now, the question here is, when educating a leukemia patient, considering the HSCT, what should the nurse include? Will it be A, donor bone marrow is transplanted through an incision in the sternum or hip? B, several weeks of hospitalizations are needed post-transplant? C, the procedure occurs in a sterile operating room to reduce infection risk? D, transplantation can be painful due to the nerves in the bone tissue. All right, take your pick, guys. Welcome to the class, Lynn. This is the first time I've seen your name. So welcome, welcome, welcome. All right, take your pick. Or I will start answering. So let me start filtering the answers from the, yeah, we have an answer from Mary Moyo, B. Okay. Who else has the letter B? We have AJ answering C. Okay. Who else has a unique answer? We have Monica answering C. Jet also answered C. Same. James also answered C. So let's start eliminating the incorrect first. Okay. Oh, you've been here with us. Okay, good. All right, let's talk about letter D. Transplantation can be painful due to the nerves in the bone tissue. Let's try to eliminate first letter D. Transplantation can be painful due to the nerves in the bone tissue. So let's mark this option. This is incorrect. Why? The reason that this option is incorrect because it is not painful. This doesn't involve invasive hammering or injection into the bone structure. No, it doesn't. What is involved in the transplantation is the infusion of the stem cells through the IV site, through the central line. Stem cell administration is going to be given as IV via central line. So it doesn't involve invasive injection of an instrument and injecting it into the bone tissue. No, it's not that painful. Okay, so this is going to involve the injection of the stem cells into the central line. So this is a wrong option. Okay. Again, this is not going to be as invasive as you have thought. What about letter A? A donor bone marrow is transplanted through an incision in the sternum or hip. Like I've said, the administration route is not going to include incision or sternum, incision in the sternum or the hip. So we're going to eliminate that as well. This is going to be IV via central line. What about letter C? The procedure occurs in a sterile operating room to reduce infection risk. Okay. Are you satisfied with that answer, guys? The procedure occurs in a sterile operating room to reduce infection risk. Well, to tell you right now, I'm sorry to disappoint you guys. It doesn't require an OR. Does not require an operating room. However, it will require an environment that is kept sterile. So it will be a room, a diagnostic room that will be kept sterile, but it's not operating room. It is going to be a diagnostic room that is going to allow the use of this kind of this kind of infusion. And of course, this will be kept sterile, but it's not going to be an operating room. All right. So I'm sorry to disappoint. It's not going to be the OR. There are other places in the hospital that would be considered as a sterile diagnostic room or treatment room. So we are going to eliminate this one. Operating room. Yeah, you have high hopes on the operating room, right? But no, in reality, we're not going to use the operating room. So we aren't going to end up with the letter B. Several weeks of hospitalization are needed post-transplant. Why? Well, our patient will be monitored continuously around this time. So our patient will be required to stay in the hospital for several weeks. It will be several weeks in order to monitor for the possible complications. We have so many complications, guys. What are those complications? Of course, infection is one, right? No matter how sterile the procedure is done, or let's say the environment, you will always anticipate a possibility of infection that can set in. To what? Monitor infections. We will be explaining to monitor for the infection. Aside from monitoring for the infection, the patient is prone to developing the graft versus host disease, the GVHD. And aside from that, we still need to support the engraftment of the transplanted cells. So it's not like, yeah, it's several weeks. The monitoring is not that easy. It's not like, hey, it's not similar to a breast implantation. Hey, I can just show up into your outpatient clinic right now and I can just go home and deal with the wounds. No, this is a highly complicated procedure that can lead to the infections, the graft versus host disease, needs frequent monitoring to make sure that the patient will not go into to manifest of these complications. So we want to make sure that our patient is monitored during their hospital stay. Now, aside from that, our patient is just not placed into a regular patient room, guys. No, they are going to be placed in a specialized unit. This is not a regular inpatient room that can be shared with another patient. No, it is going to be a specialized unit where they can receive close monitoring, they can get supportive care, and some more treatments that will support their transition. Okay, specialized inpatient room. Very strict. Like I've said earlier, we actually have this test item yesterday on the stem cell requiring sterile environment. And so you're gonna anticipate here with the assignment as far as dealing with this patient, this will require a highly skilled nurse, not just a regular nurse that will be taking care of other 4 patients that might be exposed to other infections. No, this will require much more higher level of care, that there is some kind of like a one-to-one care. Right? You're not going to allow any nurse that will just, hey, I'm going to be assigned with you today and I have other 4 patients that are sick. No, this will cause the possible infection into your patient post stem cell transplant. All right. I begin to fear NCLEX now. You don't have to fear the NCLEX. You just need to face it. Okay. You have to face the challenge, especially for those concepts that you don't know. That's how you're going to pass the NCLEX. All right. You have to engage yourself. Do not retreat. You have to force yourself to learn about the concept. Question number 3. During an education session, a leukemia patient appears restless and asks the nurse to repeat information about chemotherapy complications. What is the most appropriate nursing diagnosis? Again, the test question: during an education session, a leukemia patient appears restless and asks the nurse to repeat information about chemotherapy complications. What is the most appropriate nursing diagnosis? Is it A, risk for ineffective adherence to treatment due to denial of chemotherapy need? B, acute confusion related to leukemia cell infiltration in the CNS? C, deficient knowledge about chemotherapy due to lack of interest in learning? And D, risk for ineffective health maintenance due to anxiety about the leukemia diagnosis. So what would be the appropriate nursing diagnosis for this patient? So let me try eliminating the options. What is in letter A? Risk for ineffective adherence to treatment due to denial of chemotherapy. Well, let's go back into the scenario. A leukemia patient appears restless and asks the nurse to repeat information about chemotherapy complications. So if you're going to use risk for ineffective adherence treatment due to denial, no, this is going to make the statement wrong. Actually, the patient is actually asking the nurse to repeat the information. So that means that he is interested in learning, not denial. Interest to learn, not denial, because of his request to repeat the information about chemotherapy complications. So this is wrong. What about letter? Do you want me to do D right now? Maybe we'll skip that a little bit. Let's skip that one for now. Let's take a look on letter B. Acute confusion related to leukemia cell infiltration in the central nervous system. Do you think that there is infiltration of the CNS this time? I doubt. Maybe if the scenario stated about patient's confusion, disorientation, then I will suspect, or maybe I will use this diagnosis. But there is no supporting evidence that the patient has confusion. So there is no infiltration. That is wrong. What about letter C? Deficient knowledge about chemotherapy due to lack of interest in learning. Again, it's stated that the patient wanted the nurse to repeat the information. That simply means that he is interested to know. You're going to mark this as wrong. So this is the correct answer, letter D. Risk for ineffective health maintenance due to the anxiety about the leukemia diagnosis. Restlessness, appears restless. That's already anxiety right there. Okay, you got it. Very good. Congratulations, guys, for answering letter D. I didn't see anything else. Let's move on to the next question. Number 4. A leukemia patient with neutropenia is observed. 1 point for you guys. That's good. A leukemia patient with neutropenia is observed engaging in various activities. Which behavior indicates a need for more education? Is it A, walking around the room, B, visitors bringing fresh peaches, C, cleaning with a warm washcloth after bowel movements, and D, showering every other day using soap and shampoo? A leukemia patient with neutropenia is observed engaging in various activities. Which behavior indicates a need for more education? Is it A, walking around the room, B, visitors bringing fresh peaches, C, cleaning with a warm washcloth after bowel movements, and D, showering every other day using soap and shampoo? Okay, let me wait up until I see the last person answering this test question. All right. Looks like you have a solid understanding about this patient on neutropenic precaution. The correct answer is letter B, nothing else. Very good. Fresh peaches. Sounds yummy to me. As we know that fresh fruits are those, especially those fruits that have thin skin, they can harbor those bacteria. All right. So no fresh fruits allowed in the patient's room. We're not supposed to let them in. Need for further education. All right. I don't think I need to rationalize the rest of them. Maybe. Okay, let's take a look on walking around the room. Yeah, it's fine. The patient should be doing that. They're supposed to be not restricted if there is no clear indication. They need to have some physical activity, right? Yeah. What about letter C? Cleaning with a warm washcloth after bowel movements. Yeah, it can also help them do their hygiene, right? Proper hygiene. Non-abrasive type of washcloth, I should say. Letter D, showering every other day using soap and shampoo. Yeah, it does seem to be acceptable in order to maintain hygiene without over drying the skin. Yeah, that is acceptable. The thing that would be unacceptable this time is having this patient shower 6 times a day and will end up with very dry skin and now going to end up with skin irritation and plus skin infection. That would really require more education. So for this patient, doing showering every other day, that is still considered as acceptable, as long as they're not doing any over the top. That is still fine. Let's talk about number 5, guys. A 38-year-old woman has been diagnosed with acute lymphocytic leukemia and is currently undergoing an aggressive chemo regimen. Due to the chemo, she has developed severe neutropenia, placing her at high risk for infections. To combat this, her oncologist has prescribed filgrastim Neupogen, a medication designed to stimulate the production of the neutrophils, a type of white blood cell crucial for fighting infections. Kind of elaborate test question, right? Which lab test is most indicative of filgrastim effectiveness in a leukemia patient undergoing chemo? Again, the test question states, which lab test is most indicative of filgrastim effectiveness in a leukemia patient undergoing chemo? Is it A, platelet count, B, reticulocyte count, C, total lymphocyte count, and D, absolute neutrophil count? We talked about this yesterday. Not yesterday, today. Good. Seeing letter D's this time. That's a good sign. All right. Letter D. I'm still seeing letter C. Remember about the neutropenia that I discussed earlier? I actually expounded it with some calculation plus the severity levels, the mild, moderate, and severe. Yeah. Okay. So, the indication for this medication. So how are you going to determine using the test? So what test indicates successful or effective administration of the filgrastim? Let's screen our answers. Let's start with letter A, platelet count. Well, we know that the platelet count can measure the amount of circulating platelets in the blood, but the filgrastim does not cause any change in the platelet count. So this is irrelevant. Okay, what about the reticulocyte count? What is the reticulocyte count if you've forgotten about what this is? The reticulocyte count is the measurement of the immature red blood cells in the blood, okay? The reticulocyte count measures the amount of immature RBCs that are circulating in the blood. And this is going to assess the bone marrow function. Assesses bone marrow function. And also the red blood cell production. So we are going to eliminate that because the filgrastim will not influence the reticulocyte count. What about the total lymphocyte count? Do you think that would be the main target in the administration of the filgrastim or the Neupogen? Well, we know that the total lymphocyte count, this is going to give us the total numbers of the lymphocytes. Okay? Measures total number, let me just put a pound sign, of lymphocytes, which is basically the white blood cell involved in the immune response. However, the filgrastim is going to target the neutrophils, not the lymphocyte. So this is going to be incorrect. All right. We are going to look at the absolute neutrophil count. Remember about the A and C? Use that calculation, guys. All right. So nothing else but letter D. The neutrophil count will be the determinant that our patient is responding to the Neupogen therapy. because the target is on the neutrophils. So again, the neutrophil count will be the correct answer. All right. Neutrophil count, because the target is the neutrophil. Let's move on. Number 6. A 67-year-old man has recently been diagnosed with acute myeloid leukemia, or AML. After a detailed consultation with his oncologist, he feels overwhelmed by the prospect of undergoing chemotherapy. He worries about the side effects and questions whether the treatment is truly worth the potential hardships. What is the best response from the nurse? Option A, if you prefer not to undergo chemotherapy, stem cell transplantation is an option. B, those side effects are challenging, chemotherapy often puts AML into remission. C, you and the doctor should make this decision together. D, you don't need to decide immediately since leukemias in adults progress slowly. Again, the situation stated: a 67-year-old man has recently been diagnosed with AML. After a detailed consultation with his oncologist, he feels overwhelmed by the prospect of undergoing chemo. He worries about the side effects and questions whether the treatment is truly worth the potential hardships. What is the best response from the nurse? I'm seeing letter D, B, B, B. Okay. Let me see some more. Okay, that's a good sign. I'm seeing a lot of the B's. Okay. All right, let's eliminate the options. A, if you prefer not to undergo chemotherapy, stem cell transplantation is an option. Well, just the statement alone clearly implies that the nurse statement does not address the patient's concern directly. And the statement here from the nurse is basically implying that the chemotherapy is not beneficial. So this is going to be incorrect. Statement implies that chemo is not beneficial. Okay. And also not addressing the patient's concern directly. Not addressing concerns. Okay. Now I'll take a look into letter D this time. All right, let's take a look in letter D. You don't need to decide immediately since leukemias in adults progress slowly. Why is letter D going to be possibly a wrong answer? Well, as we know that the AML, it can progress rapidly and it will require prompt treatment decisions. This is incorrect. All right. The AML is going to progress rapidly and requires prompt treatment decision. AML is rapid progression. It's characterized with rapid progression, and so we need to have some treatment decision as promptly as the patient and the doctor can have. Okay, so make sure we're going to do that. It's not slow, so this is misleading. What about letter C? You and the doctor should make this decision together. So yeah, this is already dismissive, guys. Hey, I really don't care about you right now. Just kidding. I'm not going to get involved right now. This is dismissive. You and the doctor should make this decision together. This is very dismissive and doesn't provide the patient the needed information. Okay? This is wrong. We only have letter B. those side effects are challenging, chemotherapy often puts AML into remission. All right. So this is the most therapeutic communication being stated by the nurse. Of course, you are here acknowledging the patient's concern, right? That is one. When you are acknowledging the patient's concern and also addressing the concern and also giving them accurate information about the chemo can also be somewhat what it can at least the patient will be satisfied with your answers, right? There is sincerity in your answers. Yeah, the medication will have side effects. This is expected, or these are expected, but the chemotherapy itself can halt the progression of those manifestations, or there will be remission once the patient has received the chemotherapeutic agent. All right. So we are going to select letter B, the most therapeutic communication. Number 7, a 55-year-old woman has been battling acute myeloid leukemia for several months. Her oncologist has recommended considering hematopoietic stem cell transplant as a treatment option. She is feeling overwhelmed and uncertain about the procedure and its implications. How can the nurse best assist an AML patient in making a decision about HSCT? Is it A, discuss insurance coverage for post-HSCT care? Or is it B, ask if the patient has any questions or concerns about HSCT? Or C, highlight the positive outcomes of bone marrow transplant? And D, explain that HSCT is the only cure for AML. I'm seeing B's this time. All right, let me see some more. All right, that's a good sign. I think you're very good in answering these kind of situations, guys, especially therapeutic communications and the, what do you call this? The underpinnings. So I am very confident that you can answer these types of questions correctly. All right, let's take a look at letter A. Discuss insurance coverage for post-HCT care. I'm going to eliminate that one right away because it's not addressing the patient's immediate need for the information. Does not address the patient's need of about the info, the HSCT. Let's take a look at letter D. Explain that HSCT is the only cure for AML. Is that true? It is not entirely accurate. It is a misleading statement. Not accurate. Only absolute statement most often is going to be incorrect. So we know that the HSCT is a potential curative treatment, right? But it is not the only option. Not the only option in the treatment of the AML. Okay, and it could not be suitable for every patient. So, could not be suitable on everyone, to everybody. So basically this response is just she's failing the addressing the patient's need to have that information, which should be accurate. So this is totally inaccurate. Letter C, highlight the positive outcomes of bone marrow transplant. Yeah, you can always do that. But again, this is also a dismissive statement coming from the RN. only highlighting the positive outcomes, this is another dismissive statement. And it's not really addressing the patient's concern, the fears and the concerns of the patient on the HSCT. So we don't have anything else but letter B. Ask if the patient has any questions or concerns about the HSCT. Always start with that one. Okay, so this will encourage the patient in communicating to you, and this will also allow the patient to express their specific concerns and also their questions. Okay, so much more of a supportive statement, right? If they're going to have to encourage the patient to ask. Let's move on to number 8. A 64-year-old male with acute myeloid leukemia has been receiving outpatient chemo. During a routine follow-up, his lab results show that his absolute neutrophil count has dropped to 850 per microliter. He is concerned about the implications of this decrease and what steps need to be taken to manage his condition while continuing his treatment. What should the nurse do? Is it A, discuss hospital admission for neutropenia treatment? B, teach the patient how to administer filgrastim Neupogen injections? C, stop chemotherapy until neutropenia resolves? And D, order a HEPA filter for the patient's home. Now take a look into the value of the ANC. Don't forget about what I said earlier about the severity of the absolute neutrophil count. So let me start answering right now. Let's start with letter D. Order a HEPA filter for the patient's home. What do you think about that option? I know that is very important for us to teach the patient on maintaining a clean environment, but the HEPA filters are more critical in hospital settings wherein there is a higher risk to the exposure of much more pathogenic microorganisms. So it will not be so necessary for this patient for home use. Like I've said, this is much more appropriate when the patient is in the hospital where they are more exposed to pathogenic microorganisms. Okay, so the situation here is about a patient that is doing a what? Outpatient chemotherapy. Concerned about the implications of the disease and what steps need to be taken to manage his condition while continuing his treatment. And most often, guys, when the patient has already been treated, they're going to have already the therapy in place. They will have those standing orders most of the times. So we're going to eliminate this one. What about letter C? Stop chemo until neutropenia resolves. Stop chemo until neutropenia resolves. This is unnecessary because the neutropenia can be managed with the medication such as the filgrastim. Wrong. The neutropenia can be managed effectively with filgrastim. Remember about this medication that can boost the neutrophil count? Yeah, there's going to be no necessity to stop the chemotherapy because we can do this instead. And the discontinuation can also delay the overall cancer treatment. Okay, delays the cancer treatment. All right, take a look into the value 850. What did I say about the 850 earlier? Where did it go? Let me take a look here. Where's that? Absolute neutrophil count. I'm looking for that portion. Anyway, let me just X out here. So, letter A. Discuss hospital admission for a neutropenia treatment. What do you think about this? Answer. Well, the admission to the hospital is going to be generally reserved for severe cases. This is reserved for severe cases. Remember about the value of less than 500. This is the point wherein the neutrophil count is critically low and the patient will be exhibiting signs of infection. Okay, so when we are looking into the patient's ANC of 850, it is low, but this can be managed in an outpatient basis with, of course, the filgrastim. Okay, there is no necessity to admit this patient because, again, the patient's ANC is not severely low. Again, the hospitalization is only reserved for the severe cases whenever the patient has a very critical ANC. All right, so our correct answer here, teach the patient how to administer filgrastim injections. You probably would ask, hey, there's no information about the doctor ordering filgrastim. But like I've said, in this situation, this is going to, the task here is to eliminate those options that are actually not, let's say, not a common practice, and also will eliminate those interventions that are unnecessary. Okay, so our answer here is teach the patient how to administer filgrastim Neupogen. And here, guys, our patient already has that information. Neutrophil count dropped to 850, and most often in these scenarios, the patient already has. Is because the patient is outpatient, a problem can be solved in hospital. Only me picked B. Okay, good for you, Lynn. Is outpatient, a problem can be solved. Like I've said earlier, the level of the ANC is not severely low. That's why I pointed this out to you. I actually highlighted it. Look into the ANC. The low ANC here can be managed as an outpatient with the administration of the filgrastim. The necessity to admit the patient to the hospital will only be reserved whenever there is severe ANC drop, less than 500. And this is the time when they're going to manifest those opportunistic infections. Okay, so don't forget about that. Very tricky question. Number 9, a 52, congratulations, Lynn. A 52-year-old female diagnosed with acute lymphoblastic leukemia is receiving bleomycin as part of her chemo regimen. She is currently in the hospital for her 3rd cycle of chemo and has expressed concerns about potential side effects of her treatment. What should the nurse monitor for when administering bleomycin to a leukemia patient? Guys, we are talking about bleomycin. This is not as popularly used now, but it's still going to be one of the chemotherapeutic agents. Again, the situation stated, a 52-year-old female diagnosed with acute lymphoblastic leukemia is receiving bleomycin as part of her chemo regimen. She is currently in the hospital for her 3rd cycle of chemo and has expressed concerns about potential side effects of her treatment. What should the nurse monitor for when administering bleomycin to a leukemia patient? Is it A, low blood pressure and vision problems? B, pain and blistering at the IV site? C, pink or red urine. D, shortness of breath and wheezing. Oh boy, it seems like we are being thrown with a ton of bricks this time. Bleomycin. This is something that is not common. So I really want you to get yourself engaged with the drug, even though you're not familiar. Try to learn. This might be a savior. All right, I'm seeing letter B. We have letter A. Okay. Take your best guess. Take your best guess. I'm seeing letter B as well. Pain and blistering at the IV site. Seeing also low blood pressure. All right, let's start to eliminate the answers. Okay, letter A, low blood pressure and vision problems. Okay, well, the bleomycin does not typically cause these two side effects. We are gonna eliminate. Not typical side effects of bleomycin. They're not. What about letter B? Pain and blistering at the IV site. What do you think about the pain and blistering? Yeah, it's very important, guys, that we should be looking into the IV site more often. We have to check for the signs of irritation or, let's say, extravasation. But the medication bleomycin is there. This is not really going to be a specific adverse effect or side effect of the drug. Not specific to bleomycin. Right? Indicating that as a wrong answer. Now let's take a look into the pink or red urine. What is it? Is it going to cause a urinary problem? Well, the pink or red urine is more commonly caused by another chemotherapeutic agent known as the doxorubicin. Commonly caused by common cause is doxorubicin, but not bleomycin. So it doesn't cause any color changes in the urine. So this is going to be an irrelevant option. We only have letter D, shortness of breath and wheezing. So let's tackle this answer. Why letter D? Well, the bleomycin can cause pulmonary toxicity. That is the reason. Bleomycin can cause pulmonary toxicity. And this can manifest as shortness of breath and wheezing. So these two are manifestations of that toxicity. And this is going to indicate that they are in distress, or maybe there is a severe allergic reaction to that drug, or maybe with other adjunctive therapy. The patient here is actually undergoing what we call as interstitial pneumonitis. So it's very important for you as nurses to check this patient's pulmonary function closely, and you have to intervene with this immediately because this can really cause life-threatening complications. It is already a life-threatening complication, but you need to deal with this one right away. Now, if you are in this situation wherein you are taking care of this patient with a shortness of breath, what do you think would be helpful in treating the pneumonitis? What do you think would be your treatment? Well, of course, you're going to have to do your diligent assessment, right? You got to make sure that your patient is cleared or not cleared, but you have to do your thorough assessment, make sure that you have auscultated the lung sounds, have a fresh set of vitals. And of course, if there's a need to give this medication, to give an oxygen for this patient, then go ahead and do that. Notify the medical provider right away what is going on. You're suspecting that this patient is developing that toxicity. So you want to make sure that you inform the medical provider right away this time, okay? And possibly discontinuation of the drug would be another route for this scenario, okay? Let's talk about another question here. A 65-year-old male diagnosed with acute AML or acute myeloid leukemia is receiving sargramostim. Okay, so what is this? A 65-year-old male diagnosed with acute myeloid leukemia is receiving sargramostim or leukemia following chemotherapy. He is currently in the oncology unit for close monitoring due to high-risk condition. The patient reports shortness of breath and has bilateral crackles. The nurse's next action should be A, contact the medical provider to discuss a lower dose. B, request a bronchodilator from the pharmacist. C, request an order for furosemide from the pharmacist. D, suggest administering antibiotics to the provider. All right. What do you think about this statement? I'm seeing letter C, letter D. Okay. Waiting for the rest of you guys. I'm seeing letter C as well. Letter B, letter B. All right, let's tackle the options. Letter D, suggest administering antibiotics to the provider. Let's take a look at that one. Administering antibiotics. Okay, so the patient is receiving sargramostim. Basically, this is a drug similar to the Neupogen, filgrastim, similar. Okay, so what it's showing in our scenario, patient reports shortness of breath and bilateral crackles. This could indicate something grave for this patient. So let's take a look. Letter D suggests administering antibiotics to the provider. Well, honestly, the symptoms of the shortness of breath, the crackles, is not really suggestive of an infection that would require antibiotics. Not all respiratory conditions that will manifest crackles doesn't mean that the patient would require antibiotics. No, the primary concern is the side effect of the sargramostim, okay? It's not a bacterial infection. So the suggestion of administering antibiotics is not correct, okay? It isn't known as going to cause bacterial infection. No, eliminate that one. What about letter C? Request an order for furosemide from the pharmacist. Are we allowed to do that? Are we allowed to request an order of any medication from the pharmacist? No, that is not the practice. We are not going to get any medical orders from anyone else aside from the medical provider. The pharmacist will only help out in screening those orders if they are appropriate or if the patient may have contraindications. they're gonna talk with the medical provider if this is something that is probably, the dose is probably inappropriate. And so we're going to eliminate this one. We are not going to get any orders from the pharmacist. No way. No way. This is wrong. So when you are seeing letter B as well, request an order or request bronchodilator from the pharmacist, this is also wrong. We cannot. It's only the medical provider. It could be the DO or the MD, the nurse practitioner that is attending this patient, but not a pharmacist. Never. We're never going to get any orders from a pharmacist. All right? If this is done in some hospital settings, that is illegal. They should report it to the State Department. Okay? Not legal. It should be the medical provider. Letter A, contact the provider to discuss a lower dose. Okay, kind of tricky, right? If you are not familiar with a drug, that's why we're here. We're learning. We need to know these very peculiar medication. And so we are going to call the medical provider to discuss a lower dose. The patient has developed the shortness of breath, bilateral crackle. So what is this? This will require attention, guys. So when you are the nurse assigned to this patient, it's okay to fail it now and get it correct. That's correct, Chi-Chi. I totally agree with you. That is correct. And acknowledgement that you don't know anything is the first step to learning. If you're denying that you don't know anything, that's unsafe, guys. Most likely you're going to fail the exam. If you feel like you're confident that you know everything, that's the time that you're going to fail. Trust me. Thank you, Chi-Chi, for reminding. Yeah, nobody knows everything. So what are we going to do here in this situation? If in case your patient develops the shortness of breath and the crackles, if they're being treated with a Sargram Mustim, hey, this is an immediate, this is an immediate situation. You need to do diligent assessment. I won't make this mistake anymore. Maybe in another situation that you're not familiar, that's allowed. Assessment is one thing, okay? We're gonna make sure that we are thoroughly assessing the patient's overall state, vital signs, including the saturation, respiratory rate, blood pressure, and we also need to make sure that before we call the medical provider, we have to identify, is this patient gonna need oxygen right now? Yes, we need to. If there is hypoxemia, do not delay. If there is a need to administer oxygen, please go ahead and do that. If the patient is in a midst of like a crisis, they're probably gonna end up into a code. We don't want that either. But in such case wherein you're not quite sure what's going on, if the NCLEX would give you an option to call rapid response, call rapid response team. You initiate something like this if the patient is going downhill. All right, before a code happens, call the rapid response if there is a sudden change in your patient's state. Always do that. Are you familiar with the rapid response team? If you're not, please read about the rapid response, okay? When I was a brand new med-surg way back in 2005 in the US, the hospital that I work with just started practicing this rapid response. It was quite new, but it already, the practice of having the rapid response team in the US hospitals has happened like 5-6 years ago, earlier than we did. And so this actually diminished, it greatly cut the rate of the mortality in the hospital because with this kind of initiative, okay? The rapid response team is composed of a critical care nurse, the respiratory therapist, the nurse supervisor, phlebotomist, could be the lift team guys that will help possibly whenever there's a need to do the chest compression. Everybody will be congregating outside the patient's room, and also maybe They're probably going to be in the room dealing with this patient in a critical situation. So if there is an opportunity to select rapid response team, yeah, go ahead and select that if there is a SATA question like that. So what else would be helpful in this scenario? Once you have all the information available, you're going to notify the medical provider as well. So it can be simultaneously done, calling the rapid response team, calling the medical provider, immediately notify the oncologist about the patient's symptoms and also the findings. And along this time, there's going to be, we are going to call the rapid response team, yes, in such a case. Because sometimes the medical provider will not probably answer right away. But with the rapid response team, once they are paged, they're going to immediately see this patient. And with the rapid response team, there's also that the resident medical provider who will also evaluate the patient personally. And so you can do that. Now, again, I did not say that we're not going to notify the oncologist or the attending physician. We need to do that. Okay, we will deal with that furosemide in a minute. Okay, we're going to have to really report the manifestation. Okay, we're going to have to report the manifestation, the physical assessment that we have collected, the vital signs. I'm just adding the rapid response team, right? Okay, I'm just adding that. But as soon as you have collected your assessment findings, the vital signs, then you're going to notify the medical provider, and possibly there you will get some more orders, maybe laboratory testing. Maybe you're going to get some more pharmacological treatment for this patient. So this is going to be our route to contact the medical provider to discuss a lower dose. It kind of is somewhat kind of like hidden. The answer is kind of like, yeah, we're just calling for a lower dose. But basically the calling is inclusive of reporting the patient's overall state. Now let's take a look into letter C, request an order for furosemide from pharmacist. Like I've said earlier, this is a pharmacist, right? This is illegal if we're going to get an order from a pharmacist. That is why this option was already incorrect. Okay, so let's tackle first about the communication with the medical provider. By this time, when the medical provider thinks, hey, yeah, this patient is developing some kind of a pneumonitis. Yeah, let's give him some Lasix. Yeah, go ahead and do that as soon as you get that medical provider's order. Okay, but in this situation, we don't have an option to give the Lasix because in the scenario, it's stated that it's requesting the drug from the pharmacist. So we don't have any other choice but letter A. So in an ideal setting, like I've said, you're going to first do your assessment, check the overall state of your patient, call the medical provider. When the medical provider deems that, hey, yeah, we need to do some more testing for this patient, we're going to have to decrease the dose of the drug, we're going to have to do the Lasix, we're going to have to administer because the patient is now drowning, we need to give this medication, then do that. All right. But for this scenario, like again, the pharmacist is not the person to get an order. Okay. Please do not do that. They will refuse. Moving on to question number 11. A 58-year-old female recently diagnosed with acute myeloid leukemia is preparing to start her chemo regimen. During a pre-treatment educational session, the nurse explains the different phases of chemo and what the patient should expect. Which of the following patient statements indicate a need for more education? Is it A, I will only have treatments once a month. B, I will receive high doses of chemo. C, I might get sick during this treatment stage. And D, the goal of these treatments is to induce remission. Rereading the scenario, a 58-year-old male or female patient recently diagnosed with AML is preparing to start her chemo regimen. During a pre-treatment educational session, the nurse explains the different phases of chemo and what the patient should expect. Which of the following patient statements indicate a need for more education? Is it A, I will only have treatments once a month? B, I will receive high doses of chemo? C, I won't get sick during this treatment stage? And letter D, the goal of these treatments is to induce remission. Alrighty, I'm seeing letter C. So this time, I might get sick during this treatment. But, okay, please do not ignore this. Which of the following statements indicate a need for more education? Oh, I apologize. Hang on a second, guys. Stop answering. I made a mistake in the options. Hang on a second. Let me correct this one. And we are on 829. Let me correct that one. I got puzzled for a second here. 829. Let's take a look where that is. All right, so letter C is actually I might get sick during this treatment stage. So please check your answers. I corrected the option letter C. Again, the updated options: A, I will only have treatments once a month. B, I will receive high doses of chemo. Letter C, I might get sick during this treatment stage. And letter D, the goal of these treatments is to induce remission. Okay, alert. Option C is updated. Okay, alert, alert, alert. All right. It said I might get sick. Earlier it said I won't, but here it said I might get sick. I made a mistake in typing the word. Need for more education. All right. So I'm seeing a lot of A's in letter. Okay, a lot of A's. That's a good sign. All right, let's eliminate the options. So if you answered, I will only have treatment once a month. Remember, guys, acute myeloid leukemia, preparing to start here, chemo regimen. During a pre-treatment educational session, the nurse explains the different phases of chemotherapy. Remember about what I said earlier about the induction and consolidation treatment? Do you remember that? Remember about the frequency during the first treatment? Okay. So I want you to recall about the induction therapy. Induction therapy followed by the consolidation. All right, let's take a look on letter A. I will only have treatment once a month. And again, our patient is preparing to start her chemotherapy regimen. So basically, our patient has not really started the chemo yet. Okay, has not started yet. So here we are only going to capture that patient statement that would reflect that they do not understand about the chemo. as an initial treatment. Remember about the induction? So letter A, I will only have treatment once a month, or treatments. So this statement indicates misunderstanding of the chemotherapy schedule. Remember about the induction? This is wrong. Once a month? No, that is false. Remember about the induction therapy. It will require frequent, high doses of the chemo. Remember about the goal of the induction therapy? It is to cause remission, rapid remission of the leukemia. Remember about that? So our letter A is the wrong answer. If you said once a month, this is going to be the continuous, the maintenance, or the consolidation. This is wrong, okay? Again, this is supposed to be the induction phase, so this is wrong. What about letter B? I will receive high doses of chemotherapy. Yeah, that is true. Whenever there is the induction phase going to happen, you're going to expect the patient to receive high doses of the drug. Okay? So, this is going to reflect no understanding, but actually will reflect understanding. Do you understand this question, guys? Reflects understanding. Are you good? I'm not hearing anything, or I'm not seeing any more comments. What's going on? So here we are going to identify those statements that are false or not reflecting understanding about the chemo induction. So this is a correct statement. Okay, what about this one? I might get sick during the treatment stage. Yes, they can get sick. They can get nauseous. They can get the GI manifestations. There are so many manifestations that we should be watching for this patient. Infection is another one. Nausea, vomiting, increased risk of infection. All right. So, what about letter D? The goal of these treatments is to induce remission. Yeah, this is also a correct statement. We want to give them higher doses of the chemotherapeutic agent to what? To kill a large amount of the leukemia cells, okay? Which will reduce the leukemia cells. Rapid reduction of leukemia cells. I think only A give them the answer away as well. I will only have, yeah, this is another clue here. I will only have treatment once a month. The word itself is an absolute only. And it's not quite true as well. Like I've said earlier, that the patient is not only going to get once a month therapy during the induction. They are getting frequent chemotherapeutic agents. The sessions will be frequent during the first stages. Okay, and the reason for that is to reduce rapidly the leukemia cells. So this is going to be the incorrect statement. All right. The rest, they are true, describing the induction therapy. They're going to get sick during the treatment. The goal is to induce remission, and also it will give high doses of the chemotherapeutic agents to the patient. Okay. All right, I hope that you're learning from this scenario. Let's move on to number 12. These are very tough questions, guys. Letting you know right now. These are very tough. Number 12. A 45-year-old male has been diagnosed with acute leukemia and is scheduled to begin his chemo regimen. Before starting the treatment, the patient is admitted to the oncology unit where the nurse begins administering intravenous fluids and allopurinol. What is the purpose of these interventions? Again, a 45-year-old male has been diagnosed with acute leukemia and is scheduled to begin his chemo regimen. Before starting the treatment, the patient is admitted to the oncology unit where the nurse begins administering IV fluids and allopurinol. What is the purpose of these interventions? Is it A, to prevent DIC, B, to prevent pancytopenia, C, to prevent tumor lysis syndrome, and letter D, to prevent mucositis? All right, so while waiting for your answers, again, we are promoting to enroll to our NCLEX course at Stancoast, nclexcoaching.com. We have updated all the available perks in our system. We have 200 hours of, we have updated the number of hours in our animated videos. Same thing with our on-demand lectures. We have increased those hours as well. We have the study guides, and we also have the mock exam. So make sure that you're going to sign up to be more ready before taking the examination. All right, Masebayata answered letter C. That is a good answer. That is a correct answer. That is correct. Again, allopurinol is going to what? It will reduce the amount of the uric acid levels in this patient. Because when there is tumor lysis syndrome, remember, there is going to be elevation of the uric acid. It can cause uric acid stones. And aside from the tumor lysis syndrome, remember about the hyperkalemia? Remember about that? Potassium is elevated. The calcium is low. The phosphorus is what? Elevated. Plus the uric acid is elevated. Potassium, calcium, phosphorus, uric acid. Okay, remember those? We are going to prevent tumor lysis syndrome. It will not prevent DIC. Okay, the IV fluid and also the allopurinol doesn't have any effect in the DIC. It doesn't influence the coagulation. It doesn't do that. It also is not going to influence the drop in the blood cell counts. It doesn't. It also will not prevent mucositis. So we only have letter C as our answer here. Prevent tumor lysis syndrome. That was an easy question, guys. Number 13. A 30-year-old woman has recently been diagnosed with acute leukemia. She is admitted to the oncology unit for further eval and initiation of treatment. As part of her care, the nurse discusses the potential complications associated with leukemia. What are the three primary complications associated with leukemia? Is it A, bone deformities, spherocytosis and infection? B, anemia, infection, bleeding tendencies? C, lymphocytopoiesis, growth delays and hirsutism? D, polycythemia, decreased clotting time and infection? Is there a delay with a live? So what are the three primary complications of leukemia? Is it A, B, C, and D? Let me start answering. Letter A, bone deformities, spherocytosis, and infection. Do you think that would be that answer? No. These are not typical complications of leukemia. No, not typical. All right. Not typical complications. What about letter D? Polycythemia, decreased clotting time and infection. Infection, yes, this is correct. Decreased clotting time? Not quite. What about polycythemia? This is elevated red blood cell. This is wrong. There is no polycythemia, but anemia. So we are going to eliminate this one. Okay. What about letter C? Lymphocytopoiesis, growth delays, and hirsutism. What do you think about letter C? When we are going to encounter this word, lymphocytopoiesis, this is the production of the lymphocytes. Means production of lymphocytes. And it's not a primary complication of leukemia. It doesn't do that. This is wrong. This is not known to cause lymphocytopoiesis. So we only have letter B, which is anemia, infection, and bleeding tendencies. Okay? Remember about the red blood cell is down. The white blood cells are also down. And also the platelets is also down. Okay? Infection, anemia, and we have bleeding. All right, that's generic in a patient with acute leukemia. Let's move forward with number 14. A 45-year-old man has been undergoing treatment for acute leukemia for the past few weeks. His oncology team decides to perform spinal tap as part of his diagnostic workup and treatment planning. The patient understands the purpose of this procedure when stating A, this will help rule out meningitis. B, this will reduce intracranial pressure. C, this will help classify the leukemia. And D, this will check for central nervous system infiltration. Question 14. A 45-year-old man has been undergoing treatment for acute leukemia for the past few weeks. His oncology team decides to perform a spinal tap as part of his diagnostic workup and treatment planning. The patient understands the purpose of this procedure when stating A, this will help rule out meningitis. B, this will reduce intracranial pressure. And C, this will help classify the leukemia. And D, this will check for central nervous system infiltration. Take your pick. All right, while waiting for your answers, I'll start rationalizing this time. Letter A, this will help rule out meningitis. Yeah, I know, we can get this test to rule out meningitis. But in this scenario, this is not the primary reason for the leukemia patient. This is wrong. Not the primary reason for leukemia patients. All right, we can take that out. What about letter B? This will reduce the intracranial pressure. Well, sadly, it will not be performed to reduce ICP in the patient with leukemia. Not indicated. We are going to eliminate this one as well. What about letter C? This will help classify the leukemia. Will it? Did we talk about classifying the leukemia through the lumbar tap? No, it's a big no. This is also incorrect. It does not aid in leukemia classification. Does not aid in leukemia classification. So we don't have anything else but letter D. This will check for the central nervous system infiltration. Remember, I said earlier on a patient that may start being confused, disoriented. Yeah, that is a sign that there is now infiltration of the leukemia cells into the central nervous system, and the lumbar tap will help determine that. Okay, so they're going to see the leukemia cells in the cerebrospinal fluid. Okay. So there is now infiltration. So the correct answer is letter D. Now let's move on to number 15. Number 15. A 77-year-old retired teacher is admitted to the oncology unit with suspected acute myeloid leukemia. He presents with fatigue, easy bruising, and recurrent infections over the past month. His diagnostic workup including blood tests and bone marrow biopsy is pending. When preparing his care plan, what important epidemiological fact should the nurse consider? Is it A, early detection typically leads to favorable outcomes? Or is it B, the 5-year survival rate for older adults is around 50%? Or C, the 5-year survival rate for patients over 75 is below 2%? And letter D, survival rates are entirely influenced by the patient's health before the illness. So what would be that epidemiological fact that you should consider here? Remember, our patient here is a 77-year-old retired teacher suspected of the AML, but already has fatigue, easy bruising, and recurrent infections over the past month. So we're just waiting for the results, right? For the biopsy, the bone marrow biopsy, and the blood test. So while you are getting ready for the care, you're formulating the care plan for this patient, but you're going to base it on the epidemiological fact. And which of these facts is correct? Is it A, early detection typically leads to favorable outcomes? Is it correct? Well, we know that early detection is very important, right, to most of the cancers. Early detection is crucial. Crucial in most cancers. It will be. Including the AML. However, the early detection may provide treatment option. Yes, it can do that and improve the quality of life, but does not alter significantly the overall survival rate. But here's the big but. The but right now does not alter the poor prognosis in this age group. Remember about what I said in the AML? They have worse prognosis compared to the ALL. Does not alter overall survival rate, overall survival rate. Mistake here. Poor prognosis, I should say. Remember about the poor prognosis? Yeah, this one is correct. It is important. But this one right here leads to favorable outcomes. Not entirely correct. Remember that our patient is 77-year-old. They have poor prognosis. Okay, so we are eliminating letter A. What about letter B? The 5-year survival rate for older adults is around 50%. Overall survival rate is over 50%. Is that correct? Yeah, it is more of an overestimation of the survival rate. No, it's not true. The reality here in the elderly population with the AML, when their age increases, especially for those age over 40 or age over 75, there is going to be a drop in the survival rate. 5-year survival rate is around 50%, much lower. So this is incorrect. Lower survival rate. Okay, what about letter C? The 5-year survival rate for patients over 75 is below 2. Yes, that is the correct answer. Letter C. That is low. That's quite sad, guys. For our patients that are elderly, the prognosis is poor. So we are selecting that letter C. The AML is a very aggressive form of blood cancer. Okay? AML is aggressive type of cancer. Okay? And with the age of our patient, yeah, there is poor prognosis. Poor prognosis. Now let's take a look into letter D. Survival rates are entirely influenced by the patient's health before illness. Nope. We didn't say that earlier. Not before the health illness. Or not before, the patient's health before the illness, I should say. Okay? Yeah, we know that the patient's health before they get sick, that is very important. It can also impact the outcomes. But again, the survival rate in AML is what? Going to be influenced by, again, the disease process. Let me write this out here. Major influences. So what is that? It will be the age, okay? The response to the treatment. And also presence of comorbidities. Okay. All right. So we only have one answer, which is letter C. 5-year survival rate for patients over 75 is below 2%. Poor prognosis. Entirely looks to absolute. Yeah. Early detection, 5-year for older adults. The 5-year survival rate, yeah. Influenced. Yeah, that's gonna be a clue that that statement is wrong as well. So don't forget about those clue words. Not, yeah, those kind of things. Entirely, only. Be careful. Now let's move forward to number 16. A 65-year-old retired nurse is admitted to the oncology ward for induction therapy following a recent diagnosis of AML. She presents with fatigue, bruising, and recurrent infections over the past few weeks. Her initial lab work confirms AML, and she is scheduled to start chemotherapy soon. What should be the nurse's main priority in this patient's care plan? Your patient is a nurse. Yeah, sometimes it can be very intimidating when you are going to take care of a nurse. And I've taken care of several nurses, several doctors. Yeah, it can be intimidating, but you really need to stand your ground. And I've learned that. So your patient is admitted to the oncology ward to have an induction therapy following a recent diagnosis of acute myeloid leukemia, presenting with fatigue, bruising, recurrent infections over the past few weeks. Her initial lab confirms AML, scheduled to have chemotherapy soon. So what is your priority here? Is it maintaining protective isolation, and stringent use of standard precautions? B, providing a high-calorie, low-texture diet and ensuring proper oral hygiene? Is it C, involving the patient's family in planning daily activities? And D, monitoring and managing the patient's pain? What is your priority here? Care plan. So, once the patient will start the chemotherapy, what should you be promoting for this patient? Okay, let's start answering. Let's take a look at letter D. I think everyone has already being tired. Probably they're already in bed by now. For those who are living in North America, it's quite late. So, if you had answered letter D, monitoring and managing the patient's pain, what do you think about that? Yeah, we know that we are going to have to deal with the pain of the patient, right? We're going to have to promote comfort, and also we want to make sure that they understand about the therapy, the variety of pain medications that they should be getting as needed as well. But this is not going to supersede the need for infection control. Will be a second priority, I should say. Okay, important, but not as critical. But not critical as preventing infection. All right. So we are eliminating that one. What about letter C? Involving the patient's family in planning the daily activities. Yeah, that's kind of sounds good to me. We always involve the family. It can give them some boost, emotional support, and also continuity of care. But it's not as critical as preventing the infection, especially during the induction therapy. Induction. Remember about the induction therapy? This is a rapid means of killing the leukemia cells. So the patient will be getting a lot of the chemo drugs in a short time. They're going to be prone to developing infection, and that is why our correct answer here is letter A. Maintaining protective isolation and stringent use of the standard precautions. Letter B, yeah, we can do that, but not as critical compared to letter A. Involving the family, that is correct, but not as critical compared to preventing the infection. Always think about what can potentially be the complication is. Look for the complication of induction therapy. Okay, severe complication, I should say. Look for the severe complication of induction therapy, which is basically the infection which can occur because of the sudden drop in the blood counts. The neutrophils or the white blood cell count, that's our goal for this test question. Good for you guys who answered this question correctly. Number 17. A 58-year-old woman has been undergoing chemo for acute lymphocytic leukemia in the past month. She presents with fatigue, easy bruising, and small red spots on her forearms. The nurse notices ecchymosis on her lower back during a routine assessment. After informing the primary care provider, what should the nurse do next? Is A, implement measures to prevent blood clots. B, review the patient's latest platelet count. C, place the patient in protective isolation. And D, encourage the patient to walk to improve circulation. While you're reading the options, again, I am reminding you to enroll in our NCLEX review course and visit our website at www.stancoastandflexcoaching.com, or you can also click on the description box below for more information. All right. What is your answer here, guys? How many questions? I think I have one more. Yeah, I think I have one more left. All right. I was thinking that it would be a surprise, but you asked. All right, that's no problem. What is your answer here? But let me just do the rationalization right now. What is in letter A? Implement measures to prevent blood clots. Yeah. Are we supposed to do this? Implement measures to prevent blood clots. But here, after informing the primary care provider, what should the nurse do next? She presents with fatigue, easy bruising, and small red spots on her forearms. Okay. Whoever answered letter A, that's wrong, guys. There is no formation of blood clots because there is thrombocytopenia. This is wrong. Patient is prone to developing thrombocytopenia. Okay. So there is going to be bleeding risk. Are you sure, Melrose? Or maybe you're answering a different test item. But for test item number 17, we're going to eliminate letter A because we're not going to implement measures to prevent blood clots. We're not expecting that. The patient is prone to bleeding. There is thrombocytopenia. So preventing blood clots is not going to be relevant. Irrelevant. Irrelevant. All right. What about letter B? Review the patient's latest platelet count. What do you think about letter B? Well, we already see the patient as having easy bruising, right? Small red spots, forearms. We need to have a what? Take a look into the patient's platelet count, which is the correct answer. We're going to look at if there is thrombocytopenia. And the reason for that, to confirm. To confirm what? The low platelet count. We're going to have to review. If you had answered letter C, place the patient in protective isolation. Okay. Let's take a look into the situation here. A 58-year-old woman has been undergoing chemo for acute lymphocytic leukemia for the past month. She presents fatigue, easy bruising, and small red spots on her forearms. The nurse notices ecchymosis in her lower back during a routine assessment. After informing the primary care provider, what should the nurse do next? Is there a reason that we're going to protect the patient or put them in protective isolation? Is there a reason? Do we have a value on the absolute neutrophil count? Do we have that information? If there's no such information that can support the need for the protective isolation, then we're not going to do that. Okay? I mean, you can do that as probably a third or fourth nursing action, but will that really target the issue in the question, which is basically the concern of having that bleeding thrombocytopenia? No, it doesn't address that. My question is, won't the nurse review the platelet count before contacting the HCP? Well, they should be doing that. But let's go back into the question. The nurse notices ecchymosis on her. What should a nurse? Fatigue. Review Yeah, review the patient's latest platelet count. I think there you have a point there. Review the patient's latest count. After informing the patient, the primary care provider, what should the nurse do next? Yeah, there is some kind of like a delay here with the review. But let's take a look here. Again, in the test question, we should be reviewing. She presents with fatigue, easy bruising, and small red spots on her arms, on her forearms. So we have that information already. Most of the time, I mean, yeah, ideally we're going to have to do the review first. But in this case, in a reality setting, or in a real setting, for some reason, this nurse was probably not paying attention to the lab test. And so we are only limited to what is given in this situation. Yeah, you have a point here, A+. My question is, won't the nurse review the platelet count before contacting the healthcare provider? That is correct. We should be reviewing. But with this scenario, what do you think would be at least the appropriate measure? Okay, so in a realistic setting, not ideal. So this nurse has neglected the review first, but we'll just take the question as it is. So after informing the primary care provider, what should the nurse do next? So what do you think? We're just going to have to eliminate what we can eliminate. We can eliminate letter A. We have eliminated the isolation because there's no need really. We don't have information about the A and C. Letter D, encourage the patient to walk to improve circulation. Well, is there an issue with the circulation? Not really. So we're going to eliminate that one. So we are dealing the test question as it is. Okay. Think about what is just happening in the scenario. Okay. You can always think about the ideal stuff. Okay. But with this particular situation, there is a problem already that you can identify. Yeah, we know that the nurse has neglected to review the latest platelet count. This should be done first thing. But again, what do you think would be the best option? We don't. But other than reviewing the patient's latest platelet count. Kind of dumb, right? But sometimes we can be presented with such scenarios. You're limited to what is presented to you. Maybe it's not the ideal of all the ideal settings. Sometimes not all nurses follow the routine. That's correct. And so what you're going to do here is to, hey, what should I do next if in case I'm given with this kind of setting? Even though it's not really ideal, what can you do best for this situation? Okay. So again, just to warn you guys, not everything that you will see in the NCLEX question will be all ideal. You will be given scenarios that are probably would be so impossible to analyze, or just plainly stupid, or just dumb. But you're going to have to get ready and just eliminating those other options that will just not be possible, or will not eliminating those answers or options that cannot really solve or will not answer the question. Okay, that's what I'm trying to say here. Now 18, a 72-year-old retired teacher, I believe this is the last one, has been experiencing fatigue and generalized weakness over the past few months. During a routine checkup, his primary care provider noticed enlarged lymph nodes in his neck and groin. Concerned about a possible hematologic disorder, the patient is referred to an oncologist for further evaluation, which finding will definitely be present if the patient has CLL, the chronic lymphocytic leukemia type. So let me reread the question. It's already late on my time. A 72-year-old retired teacher has been experiencing fatigue, generalized weakness over the past few months during a routine checkup. His primary care provider noticed enlarged lymph nodes in his neck and groin. Concerned about a possible hematologic disorder, the patient is referred to an oncologist for further evaluation. Which finding will definitely be present if a patient has CLL? Is it A, a high number of immature blast cells, B, elevated lymphocyte count, C, persistent bone pain, and D, low platelet count without signs of bleeding? What do you think? Again, we're going to eliminate the options here. Let's start with letter A, a high number of immature blast cells. Guys, our case here is CLL, chronic lymphocytic leukemia. Okay, so if your answer is a high number of immature blast cells, this is going to be incorrect, because again, we are talking about what? Chronic lymphocytic leukemia. Remember about what we said earlier, that in the CLL, there is what? More mature but dysfunctional white blood cells. So it's not going to be immature. This is wrong. They are mature. Remember about the CLL? Yeah. Let's take a look on letter D. Low platelet count without signs of bleeding. What do you think about that? Low platelet count without signs of bleeding. Do you think that this is going to be the definitive manifestation finding rather for the CLL? Okay. Which finding will definitely be present if the patient has CLL? Yeah, platelet will be reduced. There is going to be thrombocytopenia. That is true. It can happen because of the bone marrow suppression related to bone marrow suppression. That is true. But it's not a definitive finding for CLL. Not definitive. Okay, let's eliminate the other ones. Persistent bone pain. If there is infiltration of the leukemia cells into the bone, it can be associated with other conditions as well. Not specific. This is not specific to CLL. Okay? It is not a definitive, consistent finding in all CLL patients. It can also be associated with other conditions, so it is less specific. So we have our answer here, letter B, elevated lymphocyte count. Remember what I said earlier in the CLL, there is going to be what? Elevation of the white blood cells. There is going to be a massive increase in the white blood cells. They are mature but dysfunctional. Remember about that. Mature white blood cells increase mature white blood cells, but they are dysfunctional. This is our hallmark in CLL. All righty. Okay, that is the end of our test items today. So I hope that you're learning, despite that it's rough, it's tough. The most important thing here is that you are digesting. If you are digesting, that's good. If you are not, then I recommend you to review this lecture and again emphasize on differentiating the different types of leukemia, so you will know for sure what can be done for this different patient. So I again thank you for your participation today, and we will be having another lecture tomorrow, more on the blood transfusion. So we'll tackle that tomorrow at 9 p.m. Eastern Standard Time, and I appreciate your participation again, and I hope really that you are learning as we are going through so many topics. That is the end goal, that you are learning. So keep an open mind, don't be resistant, because awareness that you're not aware, that you don't have any knowledge about the disease process, is the key to learning. Okay, so always think about the awareness that you're not familiar with something. Do not be resistant, guys. All right, so thank you so much for your time. Again, you take care and have a great day ahead, and you have a good night for those who are in North America and Europe, America rather. All right, have a good day, and thank you again. Bye-bye. All right, ending.